In Andhra Pradesh, there is a flagship project of the previous government, Urban Primary Health Centers, UPHC. There is a chain of urban hospitals, 225 hospitals across Andhra Pradesh, many towns and cities, which was networked across. All the clinics were networked, and it was the first digital clinic from beginning reception to doctor to lab to pharmacy. The entire process was digitized. All the records were digitized, and telemedicine specially was made available, specialist consultation in every clinic. You may be wondering, minimum per a month, 10,000 specialist consultations were happening in those days. It was a remarkable process which I am associated with. Later on, the government extended the same project to the rural areas also. It is called as sub-centers. This telemedicine technology was taken to the sub-centers. ANMs were holding the telemedicine equipment, providing rural folk the telemedicine consultation. Then COVID came. During the COVID, I am having the privilege to extend the telemedicine services across the country in association with many NGOs. And every patient from across the country, they were taking consultation from the doctors online. So in this way, I was associated with telemedicine, and I was associated with another flagship project of Government of Andhra Pradesh, RBSK, Rural, this is Rashtriya Bal Swasthya Karyakram, RBSK. It is a screening of children with a non-invasive method across AP state government, schools and junior colleges. We have screened more than 10 lakh students in a year, academic year, going across these places. And I was associated also in another digitized health program, that is an ANM online. You know, ANMs, they go to every house and collect the information of the mothers, would-be mothers and children. That is made online. So this way, I was associated, and at that time, Dr. Murthy Garu, he asked me to join TSI. That was my history of TSI. And now I am proud to say that most of our EC members, they are also associated in one way or the other with telemedicine or digital health projects. I appreciate Maheshwara Medical College, who have started a telemedicine clinic in their own premises. In this regard, I requested Krishna Reddy Garu to ask every college in Telangana to provide a telemedicine system in their own college, providing specialist or doctor consultation, which would help the rural folk. And our treasurer, Uma Mahesh, he is into digital technology. Akhila, she is into AI technology, providing health care. And most, Dr. Sadhana Sharma, she is providing a regular telemedicine consultation. And all of our people, more or less, associated in this. And Dr. Raji is a nodal officer for ESIC, All India Nodal Officer, for E-Sanjeevani. That is how our team is most into the telemedicine, which can provide health care for people away from the society, rather rural areas, tribal areas. Nowadays, I just wanted to put you something. Daily we use Zomato. Daily we use Swiggy for getting the food, or Blinkit, or Big Basket for getting other things. Why not doctor consultation at home? It has to be thought of. But of course, there are some intricacies in that. I agree. Because health records are to be protected. If they are private, they cannot be kept open. That is one of the reasons why healthcare sector is very cautious. So, this is one of the biggest area which all of us, including the students, need to think of. Because medical consultation, if it is provided to every needy person from home, how much relief we'll be having, you just think of. So, this conference is more focused in these areas, and many speakers are going to speak on different subjects, focusing on telemedicine and digital healthcare. Our TSI Telangana chapter, we welcomed many students and they joined as members. Maheshwara Medical College, just now our dean has announced that 29 students are members of the Telemedicine Society of India. It's a proud moment for us. Dr. Santosh also, who was on that day, he was here when they joined. He offered a discount of 3,000 rupees for every student who joined the TSI. Today, I request many of you who have come here to join TSI and actively participate. Why? Because this is a growing technology, a growing requirement. It is more a requirement than technological advancement. Every sphere of society requires this, especially elderly people, geriatric care. It requires, if it is provided on telephone or video call, it would be very convenient for people to take advantage of it. Today, I welcome you all to join TSI if you are not the members of the society. Today, anyone gets admission will have a 10% discount, and the students also who wants to join Telemedicine Society, they are welcome. And I know that many students from here, they are going to the rural areas, providing relief to the rural people. You can use the telemedicine effectively to sustainable health care of the rural folk. So with this, I conclude, and today, as announced, our Governor, His Excellency Dr. Shiv Pratap Shuklaji, though he agreed to grace the occasion due to his exigencies and official commitments, he could not make it today, but he sent a message which I would read out. Governor Telangana message. I am pleased to learn that the Telemedicine Society of India Telangana chapter is organizing its midterm national conference on 18 July at Maheshwara Medical College, Hyderabad. Telemedicine has emerged as a transformative force in healthcare, bridging geographical barriers, enabling quality medical services to reach people in remote, rural, tribal, and undeserved regions. By leveraging digital technologies, artificial intelligence, and innovative healthcare solutions, we can build a more inclusive, accessible, affordable, and efficient healthcare ecosystem for our nation. I commend the Telemedicine Society of India for its sustained efforts in promoting awareness and adoption of telemedicine, digital health technologies, and the responsible use of artificial intelligence in healthcare. Such initiatives not only strengthen our healthcare delivery system, but also foster meaningful collaboration among medical professionals, public health experts, technology innovators, researchers, academic institutions, policymakers, and healthcare organizations. It is heartening to note that this conference will bring together eminent clinicians, public health professionals, healthcare technology experts, AI specialists, academicians, researchers, medical students on a common platform to deliberate on emerging opportunities and challenges in digital healthcare. The active participation of young medical professionals and students will help mature a future-ready healthcare workforce capable of addressing evolving health needs of the society. I am particularly encouraged by the emphasis being laid on the family adoption program, which provides an excellent opportunity for medical students and healthcare professionals to engage closely with the rural and undeserved communities under the guidance of their faculty. Such community engagement promotes preventive healthcare, facilitates early identification of health issues, and provides valuable insights for community-based research and evidence-driven public health policy initiatives of this nature will contribute significantly towards strengthening primary health care and improve healthcare outcomes at the grassroots level. I am confident that the deliberations at this conference will generate valuable insights, encourage interdisciplinary collaboration, and inspire innovative solutions for delivering equitable, affordable, and technology-enabled healthcare to every citizen. As India progresses towards a digitally empowered healthcare system, platforms such as this play a vital role in ensuring that technology remains a powerful instrument of compassion, inclusion, and public service. I extend my warm greetings to the organizers, distinguished speakers, delegates, and participants, and convey my best wishes for the grand success of the conference. Thank you. Thank you.
Thank you, Dr. Ramachandra Mission Bhattacharya, for presenting a comprehensive vision that not only reflects the remarkable journey of the society, but also inspires confidence in the transformative role of telemedicine in shaping the future of healthcare. We are deeply grateful for His Excellency for his thoughtful message and for his encouragement and continued support towards the Telemedicine Society of India and our initiatives. Your words will undoubtedly serve as a source of encouragement and direction as we deliberate on the future of healthcare, technology, and sustainable community development. May I now invite Dr. K.J. Reddy, Orthopedics Department, onto the dais. Sir, we welcome you. We now have the privilege of inviting a distinguished leader whose contribution to medical education and healthcare administration have earned widespread respect. May I request Dr. Krishna Reddy, Chairman, SVS Medical College and President, Telangana Private Medical and Dental Colleges Association, to kindly deliver his address. Sir, the podium is yours.
Distinguished dignitaries on the dais, respected faculty members, delegates, dear students, ladies and gentlemen. Good morning to everyone. Before going to the subject, just small how we have started a medical college in Maheshwara 27 years back. I want to tell you. So my youngest brother, Dr. K.J. Reddy, he was MSET topper in 1985. 1980 he was MSET topper. Since my father expired 1 year before that, Mr. Anjaya was the chief minister. So he got the award from Mr. Anjaya. As a parent, I went to receive that award. So all through his distinction student, he went to All India PGI Chandigarh, then London. He was there for 12 years. He did FRCS, double FRCS. FRCS in orthopedics, FRCS in surgery. So we wanted, our family, my 4 brothers, we wanted him to come back to India to serve our community, our people of Telangana and at that time Andhra Pradesh. So he said, definitely I will come. We want to start a big hospital. Before that, we have seen one advertisement in paper. One medical college is sanctioned to Mahbubnagar. So then, because of him, we applied for the medical college. We got it in 1999 first batch, and we are going all advice from him only. We are taking all advice from him, and is the leading orthopedic surgeon. He came just now. It is my duty to tell, because 50% of SPS Medical College is here. 4 brothers, 2 brothers are here. Mr. Krishna Rao is very affectionate towards us, and even Mahesh Garu, I met outside. He said, "Anna Mirocharu is very happy to see you. That's why I came from Chennai in spite of busy schedule," he said. So thank you, Krishna Rao Garu. And coming to the subject, whatever I am telling, I learned from Dr. K.J. Reddy, my brother, because we have got telemedicine in our college. Long back he has introduced. So it is indeed a great privilege to be here as the guest of honor at this national conference on innovating healthcare for stronger, sustainable communities. I sincerely thank the Telemedicine Society of India Committee, Telangana chapter, and Maheshwara Medical College and Hospital for inviting me to this prestigious academic event. I congratulate the Telemedicine Society of India for its continued efforts in advancing digital health, which provides a valuable platform for knowledge sharing, innovation, and collaboration among the healthcare professionals. The theme of today's conference is both timely and relevant. Healthcare today is being transformed by digital technologies, artificial intelligence, telemedicine, and data-driven decision making. These innovations are making quality healthcare more accessible, affordable, and equitable, particularly for rural and underserved communities. Private medical colleges have an important role in this transformation. Beyond imparting medical education, our institutions must foster innovation, research, digital competency, and community engagement. We must prepare future doctors who are not only clinically competent but also capable of effectively utilizing technology to improve the patient care. The National Medical Commission has also emphasized the competency-based medical education, digital learning, and technology-enabled healthcare. It is our collective responsibility to ensure that our students are equipped with the knowledge, skills, and ethical values necessary to deliver compassionate, evidence-based, and technology-driven healthcare. Clinical practice is guided by whatever I am telling you. I learned from my brother and other experts like you. So just I am reading it. So clinical practice is guided by foundational ethical principles that help healthcare professionals to navigate complex situations. Ethics in clinical practice is inseparable from patient care. It requires healthcare professionals to integrate moral reasoning, clinical expertise, and professionalism to navigate complex decisions. Respect patient autonomy, prevent harm, and promote justice. Continuous education, reflective practice, and adherence to ethical frameworks are essential for maintaining high standards in healthcare delivery. Here I would like to share one example. When we have started in 1998, so one of the famous professor from Delhi, he came for the inspection of our college. First inspection, MCA inspection. Myself and brothers were there. So he has seen all the hospital. He has visited all the hospital, noted down some points. And also in the hospital, he said, patient is the VIP here. In hospital, patient is the VIP. You have to take care of him. Everything you have to take care of him. And he has visited medical college. There he said, I think students are here. Student is the VIP here, he said. Some students are here. So students in a medical college, they are VIPs. As per Medical Council of India's inspector, one of the inspector told us, that principle we are following even today after 27 years. Any college should be friendly with the students, friendly with the patients, and we should respect the faculty members. So many considerations. Some students will come, they may not pay fees in time. We had to just ignore and take the fees after whenever he is, because it is not a totally commercial institution. We had to give Vidya Vaidyam. Our process law, we had to help the students. Poor students are there. With that confidence. So whenever we visit other medical college, I always tell, you should consider the poor students also to take care of them. Poor patients. So like that. So I was telling Krishna Rao Garu. So in 27 years, so we never charged. Okay. In 27 years, we never charged a parent food charges. Never. Whenever functions are there, everything is free. No ticket. I told them also. So parents, they are only depending on our management. They are sending their children. They will be here for 5.5 years. They visit our college. You charge them. You don't charge them. You give free food, whatever it is there, you give free food. We are following since 27 years. So they are very happy. I am telling Krishna Rao gar also, always you should respect the parents because their children are with us. So everything, one or two children they are giving to medical college. We should take care of them. We should see that they should get good education, good morals, good ethics. So yeah, that process that should be our aim to build a good medical college. And coming to today's topic, the distinguished speakers and experts gathered here today will undoubtedly enrich our understanding of
The Indian tradition of offering a shawl and bouquet symbolizes respect, gratitude, and the warmth of our hospitality. We shall now proceed with the felicitation of our esteemed dignitaries with shawls and bouquets. I now invite Dr. Krishna Rao Sir, Vice President, Telemedicine Society of India, to felicitate Dr. Ramachandra Vishnu Bhatta Sir. Thank you, sir. It is my privilege to call upon Dr. Ramachandra Vishnu Bhatta Sir to felicitate Dr. Krishna Rao Sir, Vice President, Telemedicine Society of India, Host College. Thank you, sir. May I now request everyone present to kindly rise for the national song. Let me correct the previous announcement. Now we will have Chakrapani sir on the days to be felicitated by Dr. Krishna Reddy sir. I would also like to invite Dr. Prasanna Raj sir to be felicitated by Chakrapani sir. Thank you everyone for your kind cooperation. Now there will be national song. I request everyone to please resume their seats. As we draw this inaugural session to a close, it is time to express our sincere gratitude to all those whose presence has made this occasion truly memorable. I now invite Dr. Akhila, Secretary, Telemedicine Society of India, Telangana Chapter, to propose the vote of thanks. Ma'am, may I request you to kindly deliver the vote of thanks.
Hello everyone. Hello everyone. On behalf of Telemedicine Society of India, Telangana State Chapter, I would like to extend my sincere gratitude to all the dignitaries present on the stage, starting with Sri Chakrapani Garu, retired IAS officer. Thank you very much, sir, for your presence. We are looking forward to hear your thoughts of wisdom. Thank you, KJ Reddy, sir, for honoring the dais. We are looking forward to learn from your experience, sir. Thank you, Krishna Reddy Garu. It was a real honor to know about the history of SVS institution, and we are really looking forward to learn more and have some meaningful exchanges. Probably we might be organizing one such conference in your esteemed institution as well. Thank you, Dr. Sri Ramachandra Vishnubhatta Garu. Telemedicine chapter of Telangana has been formed many years before, but until recent times, until Sri Ramachandra Garu has taken the post of presidency, we have not seen a lot of activities to be happening. So I should specially mention his presence and his active participation and his encouragement to make some meaningful changes and bring some difference as a state chapter together. Thank you very much, sir. And coming to Dr. Remella Murthy Garu, he is the man behind formation of all the state chapters in Telemedicine Society of India. And it is a true inspiration, sir, that how you never tire and relentlessly fight for making some difference. And this year that you have announced 3 national conferences to be conducted, what you are proposing, that's a very thoughtful initiative. We are thankful for you to grace the occasion, and thank you. And we are looking forward to hear your thoughts of wisdom, sir. Shri Uma Shankar Garu, Dr. Uma Shankar Garu, thank you very much for honoring the occasion and for gracing the dais. We are really looking forward to know more about the meaningful initiatives in telemedicine and digital healthcare that you are starting with, and the kind of difference that you are offering, thoughts of wisdom, to tomorrow's young doctors who are present here. Thank you very much, everyone, for this inaugural session. Needless to mention, I would also extend my warm gratitude to all the delegates and participants who have taken their time for coming this far to this institution and participating in this occasion. Thank you very much for your presence. Thank you.
Thank you, ma'am, for your thoughtful words of gratitude. Distinguished delegates, with successful conclusion of the inaugural session, we now transition into the first scientific session of today's conference. This session brings together renowned experts who will share contemporary perspectives on some of the most significant challenges in modern healthcare, encompassing cancer care, cardiovascular medicine, surgery, and geriatric health. We hope these deliberations foster meaningful learning, stimulate thoughtful discussion, and encourage collaborative exchange. Before this scientific session begins, here's a gentle reminder to all our esteemed speakers. Every presentation has been allotted a total duration of 20 minutes. A caution bell will ring at 18-minute mark, and final bell will sound at 20 minutes. We kindly request all our speakers to adhere to the time limit to ensure smooth conduct of the conference. It is now my privilege to invite our first speaker. We now move to a subject that continues to be a major public health priority worldwide. It is my pleasure to invite Dr. Sridhar Kasturi to deliver the first scientific lecture on cardiovascular diseases, prevention, early intervention, and lifestyle management. Sir, may I invite you to guide us through your presentation.
Okay, thank you. Very good morning to all of you. So, today I am going to emphasize on prevention of coronary atherosclerotic disease. PCD almost it contributes to 13.7% of total cardiovascular deaths globally, and really almost 20.5 million deaths every year globally. So why it is important? So 25 to 28% of patients, they die suddenly, and 50% of the patients, they die before reaching to during the first hour. During the first hour, 50% of the patients can die. So that is the reason first hour is very, very crucial. Even if they survive, annual mortality, first year 10% and 5% of the people die every year. So overall, 35 million people have acute coronary or cerebrovascular events every year. Disease is only one single entity, that is atherosclerotic disease. That is because the plaque formation in the heart blood vessels. Suppose if it affects the coronary arteries, that is coronary artery disease. If it affects the cerebrovascular system, that leads to strokes. If it affects the peripheral vascular system, it can lead to claudication of the limb or loss of the limb. See, in what way we are different? When compared to Americans, we have a 3 to 4 times increase in risk. And compared to Chinese, 6-fold higher risk. And Japanese, almost 20%, 24-fold high risk. So that means genetically, we are more prone. And most of the Indians, they suffer from heart disease at a very young age. We see massive attacks at the age of 25 years, 30 years. That is very peculiar. And when they present most of the time, patients will have a multi-vessel disease. They will have a left ventricular dysfunction compared to Western. And disease onset is about 1 decade earlier compared to Western population. So what are the symptoms? So majority of the patients will not have any symptoms. And when they present with the symptoms, they may have a chest pain, difficulty breathing, giddiness, palpitation, syncopal attacks, or sometimes it may be anginal equivalent. Anginal equivalent means patient may simple, they may present with like acid peptic, they may have burning pain in the upper abdomen. So sometimes Even they go and present to gastroenterologist only. Sometimes he may undergo upper GI endoscopy. So, if you see, especially family history, sex and age cannot be modified. Whereas these are the modifiable factors. During COVID time, the importance of air pollution highlighted throughout the world because there was significant fall in the cardiovascular illness during COVID illness. See, dietary risk many times we underestimate. And sedentary lifestyle, hypertension, diabetes, cholesterol, all these will contribute to coronary artery disease. So, if you don't take proper diet, if you don't do proper exercise, there is a chance of increasing, there is a chance of getting high blood pressure, diabetes, cholesterol. All these will contribute to atherosclerosis. Ultimately, patient may present with cerebrovascular accidents, arrhythmias, or myocardial infarction, or left ventricular hypertrophy. You see the top leading cause of preventable modifiable cardiovascular risk disease. You see, hypertension stands first. You see the statistics. These are WHO statistics. Hypertension followed by high levels of LDL cholesterol and air pollution, smoking, and diabetes. See, many times hypertension is under-detected and they don't diagnose it properly. Even if they diagnose many times because asymptomatic patient, they don't take proper treatment. Even doctors also, if they give a treatment, they don't give adequate treatment. So if you control it adequately, you are eliminating the risk. If you are partially controlling the hypertension, you are only partially eliminating the risk of the high blood pressure. You see, globally, almost 1.1 billion have been suffering, and they expected to, now the 2025, almost 1.6 billion people have been suffering from hypertension. It's a silent killer. In Indian adults, if you see, almost 1 in 3 will have it. Every family member, if you see, one or alternate family will have a high blood pressure or diabetes or cholesterol. For every 20 by 10 millimeters of mercury raise in blood pressure, you see, almost twofold increase in the risk. That means higher the blood pressure, higher risk. If you reduce the blood pressure, the chance of risk, you are going to reduce it. And meta-analysis of 61 prospective observational studies have shown very, very clearly, even 2 millimeters of mercury blood pressure reduction decrease the cardiovascular risk by 7 to 10%. So, benefit is very significant. So, it may lead to end-stage renal failure, myocardial infarction, congestive cardiac failure, VTBF, stroke. Finally, leading to death. All this will contribute to death. So, you should be familiar with the ABPM monitoring, OBP monitoring. Always treat with the guideline-directed therapy. If patient develops side effects, alter the doses, whatever best suits him, you give him, and avoid irregular treatment. And treatment should be consistent. You have to continue regularly to get the best results. So these are the prevention benefits. Weight loss, almost 5 millimeters of mercury reduction, and diet also 11 millimeters of mercury. So these are all important aspects, but everybody neglects these things. Reduce the intake of salt, enhance the intake of potassium, and physical activity. So if you follow these, you can prevent the high blood pressure. Diabetes, most of the time associated with the high blood pressure and hyperlipidemia. And majority of the diabetic patients, they don't die because of the diabetes, they die because of the cardiovascular illness. Almost 65% of deaths are attributed to cardiovascular death and mainly triggered by the high lipid levels. So, there is exponential increase in the diabetes incidence in India. So, we were second to in China, but now we are leading the number 1 cause. So now you see in diabetes, if you control the high blood pressure, the event rate is much more less compared to simple anti-diabetic treatment. So any diabetic, if they have hypertension, aggressively treat hypertension, aggressively treat lipid therapy so that the MACE reduction is going to be decreased very significantly. And always monitor the HbA1c. For every point reduction, increase in the HbA1c, there is a 14% increase in the MACE rate. These are statistically proven, consistent, linear increase. So frequently monitor, see that your HbA1c is, you are going to maintain below 6.5. But many times patients come with 11, 12. These are very abnormal numbers. So monitor blood pressure, blood sugar regularly, keep it under control. And cholesterol, if you see this is an inter-heart study. Among all risk factors for myocardial infarction, most important risk factor is hyperlipidemia. Combination of risk factors triggers the event. So many times it's asymptomatic, but so even in the absence of if there are no symptoms, assess the risk factors, control the risk factors. So all studies have shown very clearly, higher the LDL levels, higher the MACE rate. So that is the reason, keep the LDL level low. So from the age of, the disease starts in the first decade of life. So as the age advances, the chance of proneness for atherosclerosis is very, very high. That is the reason, early and aggressive control of lipid levels prevents the heart disease. So every 10% reduction of blood cholesterol produces 20 to 30% decline in cardiovascular events. So that means this is statistically well proven. Don't underestimate. You may be asymptomatic, but frequently check the cholesterol, frequently check the blood pressure, frequently check the HbA1c level. If you maintain the LDL level below 50, so higher the value, involving the more sites of the vascular sites, very high. So if the higher the value, chance of getting stroke, chance of getting myocardial infarction, peripheral vascular disease, very high. So you have to continue the treatment regularly. Adherence to the treatment, very important. The statins, when they discontinue, the event rate is very, very high compared to the partial adherence and completely discontinuing treatment. When you compare those who are taking regular treatment with the consistent doses, the event rate is much lower. You see the LDL level, higher the value, event rate is high. This side is the event rate. When you maintain the LDL below 50, event rate is 4.4 versus when the LDL is more than 190, this is 34%. That means the value of LDL is highly valuable. Please maintain LDL level as low as possible low. These are the primary prevention trials have shown consistently 37% reduction, 36. All studies have shown consistent reduction in the event rate when you control the LDL level. These are secondary prevention trials, again showed consistent 35% reduction, 25%. So all studies have shown there is a consistent reduction in the cardiovascular event rate if you reduce the LDL levels. So numbers are very important. So LDL level, please, Indian diabetic maintain below 70. Indian should maintain LDL below 70. HDL should be maintained above 40. Suppose if you are having a doubt whether to take it not, at least take the calcium score. If the calcium score is high, definitely you should take the statin therapy. That's very important. So you have a combination of drugs. Now wonderful drugs are there. So statin therapy is mandatory. If statin unable to control, you combine the statin with histamine, and then you can add bempedoic acid. Still not controlled, you can give it the inclisiran, or you can go with the Repatha injections where you can drastically reduce the LDL levels. So unhealthy diet, very important in producing obesity, and lack of physical exercise. So when these are there, family tendencies there, and if you add other risk factors like tobacco, alcohol, it adds more and more risk. So that's the reason always pay attention to go for exercise and maintain a healthy diet. The smoking, if you see, almost 4,000 chemicals are there in smoking, but 200 are very, very poisonous. Main culprits are nicotine and carbon monoxide. So it produces vasospasm. It can trigger the platelet aggregation. It can lead to thrombosis that lead to coronary events. And if you stop smoking, within 2 years, you are eliminating the risk related to the tobacco. So that's the reason. Please don't smoke. If you are not a smoker, please encourage others to discontinue the smoking. That's very important. So all forms of tobacco is very, very harmful, and there is no safe level of tobacco. And alcohol, always keep away alcohol. Please don't consume alcohol. Discourage everyone. but Telangana, it's a brand. Almost like a brand ambassador. But please discourage. At least the doctors' community is there. They starbucks the medical owners are there. They should encourage. So obesity, again, very important. There is a 2 to 6 times risk of developing heart disease. So please avoid gaining weight and shed the extra kilos. Go for regular exercise. Eat before what you eat. That's very important. Whatever you eat, please pay attention to it. And for every extra kg of fat, there is a 20 milligrams more production of the cholesterol. So that is the reason, please pay attention to the weight gain. If weight gain is there, go for exercise. Now the wonderful drugs have come, especially GLP-1 agonists that can reduce the visceral fat, the fat around the heart and intestinal fat. It can remove and even it can reverse the early stages of the fatty liver. That the wonderful drugs are there. You can use those drugs. Exercise regularly, at least half an hour exercise per day, 5 days in a week. WHO recommended for young persons at least 60 minutes of exercise. If it is aggressive exercise, 15-20 minutes per day, at least 5 days in a week is very, very important. Exercise is mandatory. And those who walk regularly, the mortality rate is reduced by half. So life is prolonged, very, very important. And exercise significantly reduces the chance not only the heart disease, even it prevents the diabetes, hypertension, and the risk of stroke it eliminates. And as per the India today, almost 10 to 20% of the school children are obese, and almost 2 to 5% are obese, and 10 to 20% are overweight. So that's the reason. Please pay attention to your kids. Mothers should take care what they are cooking, what kind of food they are advising, cultivate. So nowadays they are pampering the children. They are going for all fast food. That should be discouraged. More vegetables, fruits that should be cultivated in the daily life. And the regular exercise means just walk. That's enough. No need to go to gym and do. If you are going, that's fine. If that is not possible, regular walking also helps. The onion, garlic, which are usual supplements in Indian diet, is very useful to health. And at the same time, fruits and vegetables, especially those are green and yellow, definitely very useful to heart. That prevents the heart disease. And choose non-fat and low-fat products. Switch to toned milk if you are instead of toned milk, slim milk you can take. At the same time, use less fat meat like a chicken. Don't take skin. Don't take liver. And at the same time, muscle. If you are taking red meat, also try to consume less. Prawns also will have plenty of fat. Fish you can substitute. Fish is very healthy. So good diet and exercise reduces the incidence of obesity. Increase the HDL. That is one of the advantages. Lower the LDL, total cholesterol. And it also prevents the diabetes and hyperlipidemia. Usually, but majority of the kids, you can see, they are becoming like this. But usually, the fatty meat, organ should be avoided. And milk fat should be avoided, especially desi ghee, butter, cheese, malai, rabri. These things should be avoided. And bakery items, very, very high with fatty content. That's the reason those things should be avoided. And regarding oils, what oils are very important? Fish oils are very beneficial to the heart. And those oils with FUFA and MUFA are very healthy for heart. Avoid the saturated fats, especially coconut, palm oil and ghee, where plenty of saturated fat. These things should be avoided. Usually rotate the oils. If you have one oil, 2-3 oils you can use. Like 2 items, you can use one oil, another item you can use the. So mixture is very important. Salt, definitely consume moderate. It increases the chance of heart disease. The benefit is multifold. Each risk factor has associated multiple, it produces multiple diseases. That's the reason always try to control the risk factors so that you can get the multiple benefits. So definitely depression and those who are pessimistic has associated with an increased risk of heart disease. Be optimistic and be jovial and be friendly. Don't be courteous with everyone. Don't be jealous. And all these things will have associated with heart disease. And if you have a family tendency, cultivate good habit, go for regular work, and more discipline is required. The wonderful drugs have come. So all these things, if you follow, definitely you can prevent the disease. Now statins are there, inclisiran, Trepata, these we have to start early, the strong family history there, so that we can prevent the heart disease. So you can see the benefit. If you are not smoking, you can reduce 28% drugs in the cardiovascular events, and exercise reduces the 17% risk. Ideal weight reduces the 14% cardiovascular risk, and ideal weight reduces the 14%. So after MI, these targets are very, very important. LDL maintain below 70, A1C below 7, and BP target, how to maintain in the normal range. And always use GLP-1 receptor agonist and SGLT2 inhibitors are very useful in reducing the cardiovascular events as well as renal disease. And statin, HDPM, PCSK9 inhibitors are very useful. And now, last two slides. You see that cardiology has contributed to more than 50% of the lifespan prolongation. See, at the time of independence, the average Indian lifespan was 37 years. Now it's 67 for males and 70 years for females. So lifespan prolongs significantly to the so much development. The medicine contributed so much. So always avoid the risk factors. And finally, to conclude, so thank you one and all for paying the attention. Please pay attention to the diet and exercise and control of the risk factors. If you control the risk factors, if you pay attention to the exercise, and if you take a good balanced diet, definitely you can prevent the heart disease. Thank you one and all.
Thank you, sir, for your valuable insights into preventive cardiology and the importance of timely intervention and healthy lifestyle practices. We now welcome 2 to 3 questions from the audience. I encourage the audience to participate in this question and answer session. May I now invite Dr. Adams, Medical Superintendent, to felicitate Dr. Sridhar Kasturi, sir.
Sridhar, can you just hold on for a minute? I just want to ask one question for the benefit of everyone. There is a lot of confusion about blood pressure. Does it vary with age? People say if you're above 60, it's all right to have BP around 130, 90. What is your recommendation to maintain blood pressure? And is there any age related?
No, actually, previously, so people were saying that at advanced age you can keep the systolic pressure 170, 180. That's okay. But now recently, International Society of Hypertension, European Society of Cardiology, American College of Cardiology, they have given clear-cut mandate. Even Indian guidelines also very mentioned, because this guideline changed the numbers based upon the SPRINT trial. The SPRINT trial has shown very clearly where they have maintained aggressive blood pressure control with aggressive treatment, they reduce the events even further. So ideal to maintain 110 to 130 and even 130 to 140, event rate is more. when compared to 120 to 130. So 185 above, now they have mentioned high normal. So it should be maintained below 135. And ideally, if you get 120 to between 110 to 120, ideal. But higher the value, higher the risk. So at the same time, we have to balance, is it tolerating treatment or not? But there is no, like 140 above, 100% he requires treatment. No such way. But the chance of getting high pressure, high blood pressure, more with advancing age. If you see above 60, chance of getting high blood pressure is 60%. More than 70, chance of getting almost 75%. So higher the advanced age, increase the chance of risk of hypertension. Because arterial stiffness increases, more exposure to risk factors, all will contribute to CKD incidence is going to have. Definitely, the advancing age increase the chance of this. Thank you very much.
Thank you. All right. It's, I think, a small world, see that. On keys. That's all. Thank you. Good morning. Is on? Can I have my mic or? Good morning. After wonderful talk about the heart, I think everyone must be thinking what they're going to do from tomorrow. Going to do exercise, diet and weight. Thank you very much for invitation, Krishna Rao Garu and the team. I'm privileged to be here and expressing my thoughts about digital and AI future in India. And my brother, I think, already mentioned about our medical college. I think can I have a hand mic otherwise? Medical college, SVS Medical College. He is the founder chairman and he is the one who started the medical college. I was in UK that time and he called me back to be part of it. But he is the main person who thoughts were executed. And he's like our father because there's so much of age. There's 10 years gap difference, age difference between me and him. And as you know, we started in 98, our hospital, and 99 was the first batch. Telemedicine, I think nice words said about. It's like Swiggy and Zomato. I think I use a lot of telemedicine. My online appointments are booked next 3 months. And it's become so convenient. Nowadays, what happens is about 30 to 40% of my patients come from out of the state, out of the country. Previously, the biggest problem was to follow them up, see their x-rays, see their progress. Now with video consultation, we were able to see them, talk to them, examine them over the video, and they upload all their x-rays, their reports, and it's all confidential. I use Apollo 24/7 app and other apps, millions using Apollo 24/7, and all integrated. The medical record is kept all the way through, and it's very confidential. Nobody can access except the doctor concerned and the patient, because patient data is very critical, and the data theft is a big problem across the world. Coming to my talk today, I thought the technology is the future. And that's my declaration. No payment was done for this talk. And of course, technology. Other day, someone was asking me, sir, AI is going to replace us. In future, all the jobs are done by robots or technology. That's not true. It's not going to replace. human beings, but it will replace people who are not trained in the technology. Those who integrate technology into their career, they will flourish. So it's important, especially for the youngsters, to get trained in technology. Otherwise, you will perish. And I think a lot of improvements have come. There's so much going on in AI every day. Is monitored, all of us monitored by AI, where we are with our iPhone or with the watch. Google is monitoring us, and how many people are there, what you are talking, what images being displayed. So it is very important that we know what we are doing. And this is the feature value of digital technology, AI, and so much. So some of the youngsters can be innovators, can invest in AI, become the leaders in health and AI. So you can lead the future. Especially in orthopedics, AI plays a big role. The incidence of medical legal cases come down significantly. People attending emergency medicine, casualty, especially across the world, especially America and Europe. Previously, any missed fracture by a doctor was sued. With technology, AI technology, I think the recognition or diagnosis of fracture rate has gone significantly. Middle of the night, somebody comes up the fall, get an X-ray, you may not be able to identify the fracture. If you miss, they continue with the pain, they come back and repeat X-ray, or senior person seeing the X-ray will identify. And the person who saw first may be sued. So that is replaced by AI. So there's a big role of AI in musculoskeletal radiology. And there's so many softwares have come because the machine, computer will have thousands of X-rays. If you put an X-ray, it will tell you what is the condition or is there any fracture. Especially osteoporosis. Previously, there was no single test to detect osteoporosis. But now, with AI, we can detect especially early. I just want to know how many orthopedic doctors are there here? How many are? So that I can modulate my students. Orthopedic PGs, yeah, okay. Thank you. And of course, we have to learn. Otherwise, difficult to see the results. And of course, this is what I've been saying. So there's thousands of X-rays put into the machine and it will match. And it doesn't take much time. So accuracy goes up significantly. Some of these examples you can see, there was not very obvious, but you can later on, you can see there is a fracture. This is a common fracture attending emergency room, middle of the night. And of course, you can see whether your operation is right or not with AI. Because people have loaded good X-rays, good results. So you can put in an X-ray and you can ask whether what percentage of my operation is to the average or to the standards, minimum standards. And of course, previously what happens is data analysis, publication was very difficult because we had to keep everything in the shelves or in the computer. Now with AI technology, with a simple app, you can upload all the X-rays and you can ask for analysis and you can design how to analyze, design, study, execute, and you can ask for results and easy to publish papers. And of course, in a spine fracture, detection is very difficult with standard X-rays. With AI technology, you can have very high rate of detection. And similarly, in orthopedics, knee injuries, ACL, PCL, and cartilage damage, you can identify, you can quantify what is the amount of damage. And especially in osteoarthritis, now we are able to do cartilage mapping get an MRI scan, we can do cartilage mapping and find out how much damage is done inside your knee and what would be the appropriate treatment. And so many apps have come, you can see. And of course, in orthopedics, robotic orthopedic surgery is ever changing since the times it started in the knee replacement, hip replacement, spine surgery, trauma, and in sports. Because AI or robotic surgery very convenient for orthopedics. We have a fixed bony landmarks. So very easy to assess the robo to define the landmarks and assess whether you've done the right operation or not. We are restoring normal anatomy. Orthopedics is nothing but restoring normal anatomy, restoring normal movements. So you can assess very easily. And why technology? Of course, as I said, if you don't integrate into technology, very difficult to survive in future. So in 1950s, for any knee replacement or hip replacement, we used to have static plan, get an X-ray, plan, and probably we don't know that planning works on the table because the X-ray may not clearly say what was there inside the patient. And in 90s was computer navigation. We are among the first to buy the computer navigation in 2006 from Germany, Brain Lab. And of course now robotic assisted surgery, which is very popular. So we started, I'm from PGH Chandigarh, we started in the 80s. We are among the first ones to start knee replacement surgery in India. So those days, difficult, because we used to take about 3.5 hours for each knee replacement. Now things have changed. We can do it 25 to 30 minutes because of the technology, because of understanding, because of the instrumentation made very surgeon friendly. And I worked in Royal London Hospital. I'm sure some of the orthopedic surgeons know Mike Freeman, who invented knee replacements in Europe. He is among the two who invented knee replacement. I was the last registrar to work for him. And there we started some of the navigation. And what happens, I'll give you an example of knee replacement. Conventional, we use guides to cut the surface and accuracy is not great. It's about 70 to 90%. And in femur tibia, I don't go into details, but there's so many publications saying that robotic assisted knee replacements, the patient satisfaction is much higher because the pain is less, we cut less tissues, faster recovery, and they regain muscle strength much quicker. As you know, the significant number of patient dissatisfaction following knee replacement, so many reasons are there. I don't want to go into detail, but that can be reduced using AI robotic assisted surgeries. These are all technical, and what I'll just show you what exactly happens. This is conventional. This side is conventional, and this is robotic. So the optimum range was within that circle. So we are able to get many patients within expected range. So the outliers are less. And always there is a learning curve. And we used to say in the past, you have to work with a surgeon, experienced surgeon, maybe 5 years, 10 years. Then only you become good orthoplasty surgeon or orthopedic surgeon. With AI, that has changed. You don't have to work so many hours. It is reducing the amount of learning, especially for youngsters. You don't have to work 10 years. Maybe a couple of years, you are good with computers and you can be expert surgeon, provided you know the normal anatomy, normal knee replacement. So the learning curve has come down significantly. Surgeon also, what happens is, because especially when you're operating on VIPs, what happens is a lot of stress. So many phone calls will come, somebody will call the operation tomorrow schedule, so many things will come. And once you become experienced surgeon, you know what would be the difficulties. It's more difficult to rather deal with the attenders rather than the patient itself. So this reduces the stress because you planned. You took a CT scan, you know what you're going to do, and you execute in the theater. You also know what you planned you're going to execute, and whether you've done the right thing or wrong, computer or a robot will tell you. So the stress levels of surgeons will come down if you use a robotic assisted surgery. So I'll just tell you what exactly robot does. I think that's there's no video support for this. Any? Not playing. Not supported. Any? No. No, it's playing here, but I think your projector. Does it support? There is no video. Okay, no problem. That's, I think, what happens is robotic surgery. Most of the people think that robot will do surgery. It's not. We do the surgery, but instead of using hand instruments or hand saw, we use robotic arm. If we cut with a saw with my hands, there will be error of 1 millimeter. If we use a robot, it's about 0.1 millimeter. What we do with robotic surgery, we take a CT scan of the knee, we see the alignment, the deformity, we see how much is damaged, we measure the size of the knee joint, the 3 components in the knee, we size the size of the femur, tibia and the patella, and put into the computer, and during operation, we cut exactly what we planned. See, this is the robo cutting, and this is the monitor. It will tell us how much you are cutting, and safeguard. We keep away from the vital structures, nerves and arteries, so that it doesn't damage. Yeah, it's coming. Yes, I can see. Thank you. So that is the robo cutting, and you can see on the monitor which part is being cut. There is instant feedback. And you monitor throughout. It takes about 6 to 7 minutes to finish the procedure. That's a burr cutting the femur, and the burr finish is in diamonds and jewelries. Burr is a precision, is more than a saw. So this is one of the burr-based robo. There are saw-based robos as well. I use that one as well. And once you have the final product, and you can check instantly whether your cut is right or not. It will show on the screen how much you cut, how much is the size. And what happened, this is I think difficult only orthopedic surgeons to understand. Deformity, we started with the deformity, and we correct the deformity and by placing the implants. And post-op radiographs will be excellent. That's you can see, in the past we used to make a big incision. With the robotic, the incision has come down, so the pain is less, muscle recovery is faster, and they happier patients. So this is a severe deformed knee, as you can see, very deformed knee. With the conventional, probably it would be difficult to correct the deformity at the bony level. What we used to do conventionally, we used to release all the tissues, make it straight, release the ligaments. But with the robo, we do not release the ligaments. We correct the deformity in the bony level, which is the culprit. So that is an extension, this is a flexion. And you can see, final check. Same gap. We check the gap, that's a 13 millimeters, 14 millimeters, 12 millimeters, 13 millimeters. So the gaps balanced means knee is straight. So there's so many people, example, I'll take 2 more minutes. So people previously had operation, this patient had a nail. To do conventional surgery, we need two operations to take the nail out and do the knee replacement. With the robotic technology, we can keep the nail in and do the surgery because we don't use the jigs. And of course, the total hip replacement also become very easy. Positional cup, positional stem, and the balancing, soft tissue balancing becomes very simple because on the table you can check whether the balancing is correct or not. Spine surgery, robotics are very useful. Arthroscopy, very useful. And clinical evidence, the immediate results, because the robotics have been in maybe 5-6 years. We have to wait maybe 10, 20, 30 years because we can't say today done knee replacement is successful by saying tomorrow X-ray. It has to survive 20 years, 30 years. That's the biggest problem with the knee replacement. You can't say knee replacement successful after a few days. It has to survive benchmark of 10, 20, 30 years. Then only you can say the knee replacement is successful. And of course, so many studies are there. Of course, the challenges today is high initial cost, sometimes initial stage, little longer duration, and anesthesia little longer. It needs extra skills, probably initially longer learning curve. It does not replace normal surgeons. It will only replace untrained surgeons. So, take-home message would be AI and robotics are transforming both radiology and orthopedic surgery, higher diagnostic accuracy, more predictable surgical outcomes. So we can predict what we're going to achieve by planning and achieving on the table. Because we do the operation, get an X-ray, the operation theater. Here, you can rectify on the table itself. And it's a personalized procedure because every knee is different. In a conventional procedure, what happens is standard knees based on European skeletons, 1, 2, 3, 4 sizes. Here, we can design your own knee with using robo. So we can accurately measure your knee and we can personalize your knee replacement surgery. Of course, future is collaborative, precise, and intelligent. What I would request for the youngsters, be the leaders, innovators. India is global leader. And with current Modi government, there's so much is going on. And recently announced startup company, especially for the doctors, innovative healthcare and AI in healthcare. Thank you once again for Krishna Rao Garu and their team for having me here. And thank you once again. Question, okay.
Namaste, sir. That was an excellent talk, and almost you brought us up to today's standards in orthopedics what you're doing. But I would like to ask you for the next step. I think probably, as you know, predominantly all our population is rural.
Yeah.
And I think this surgery is mostly done now in the urban areas. So, and then we are trying to work in the rural areas by setting up the telemedicine clinics. So the next topic which I'm interested in is telerobotics. So can you throw some?
Yes, it is. I think what
questions, sir? I'm sorry.
Sure, go on.
There are 2 questions. One is telerobotics and how it can be utilized in rural areas where there is so much of pathology there. We have been doing a study there. In our health camps, 70% of the people have arthritis.
Yes.
That's all over the place. And because they carry weights and they don't have any mechanics and they are drinking because of that. So your surgery and helping the people will alleviate so many problems. And I'm looking forward to your answers.
Sure. I think that's it. Telemedicine, I think what happened is now the globe has become very small. I see patients from remote places in African countries or in Assam, West Bengal, because of the telemedicine, video consultation. And there is some of the not orthopedic robots, but general surgery robots, especially prostate surgeries and other surgery. There is telemedicine. You can monitor from a city to do surgery in remote places. And one more thing, the robotics initially they were sold very high cost. Now, because companies, now robo is free, provided you do their implants. Previously it was about 12 crores. Now robo provided free. We have robo in SCS Medical College, and we do very low cost. I mean, knee replacements we do cost to cost. 1 lakh is knee replacements. If they pay 1,20,000, the robotic knee surgery. So what happens is, robo is provided free, like orthopedic instrumentation are provided free. Robo is a tool. So companies become so competitive, they are providing free, provided you do their implants and do certain numbers in a year. If you do about 200 knee joints for that company, they will provide robo free of cost, and you buy their consumables. And other question, I think remote, I think very soon it will happen, because there's so many surgeons across the India, remote places, if they have a good setup, and robotic surgery doesn't need a big setup. Any ordinary theatre or optimal theatre, and they can set it up with telemedicine, orthopedic robots, they're working on it. I mentor, I'm proctorship for a few countries, African countries, Indonesia, I proctor from here. So it is possible, provided you have the trained orthopedic surgeon, you can take him through the operation. Thank you. Yeah, go on.
My question is, are there any recent advancements that are being made to help with the rehabilitation of patients after a fracture or after knee replacement?
That's a very good question, because orthopedics is nothing but rehabilitation. Surgery is 50%, rehabilitation is 50%. Unless they are rehabilitated, make them back to work, back to their normal activities, no point of doing a big surgery. There is a big robotic rehabilitation, and it's more useful in rehabilitation, because lack of time, I did mention that there is a big role, because there is structured monitoring, and you can assess the patient. Previously, what happens is the assessment was mainly subjective. Now, with the robotic technology, AI technology, you can assess objectively, and you can monitor. So, there is a big role in rehabilitation, AI and robotics. Thank you. Yeah, go on. Mike.
Predominantly, as I mentioned, we are working in the rural areas. So, rehab, we cannot set up rehab centers. If you can throw some light on, are we all doing any tele-yoga? So,
yeah, I think rehabilitation, yes, rehabilitation. What happens is, because, as I said, majority of my patients come from across India, so rehabilitation is very, very important. What we do, we bring one of the physiotherapists from the area, they come here, spend some time, they go back, and we monitor on video consultation. So, what they do first, 6 weeks is very important for a knee replacement. So, they go every day to the patients, they show the exercise, they make them walk. They also see any problem with the wounds, with their general health. They big video consultation, they will be physiotherapists. They are the best rehabilitation. They are the best people to rehabilitate the patients. So, not only physiotherapy, they update us, they progress for our progress. That's, I think, very interesting. That's very much possible. With the telemedicine, you can, I think, train people, they have to come, train them, physically they have to see, they go back and they can do the video. Absolutely. Yeah. Yeah. Absolutely. Even people in Hyderabad, some of the people do not come to follow. They do online booking, video consultation, ease of convenience. So I think future would be telemedicine and teleconsultation. Yes, thank you.
May I now invite Dr. Sabit Syed, Dean, Maheshwara Medical College and Hospital, to felicitate Dr. K.J. Reddy.
Can I take a picture with Mr. Rogan and my brother? Sir.
Small, he had 10 million. When he was 11 years elder to me, when he was very small boy, my mother used to go to field to see the fever. 6 months old boy. I used to keep the feed when she was away from home. So then we shifted to other place for high school. So he was in the village only. Whenever we come from, after 1 week, we come from this high school to home. He used to cut hold of my legs like this. And now, like that. Very affectionate. So after some time, he became famous orthopedic surgeon. So one day he said, your knees are damaged. So as a geologist, I worked at various places in India. So various places like Bihar, UP, Banaras, so many places I have worked in geological survey. So at the age of 60, I got this, my knees were damaged. So he said, so we have to replace. So 14 years back, he replaced my knees. So still, today, nothing is, yes, I have refreshed knees. So that is the affection and that is the expertise he has got. Very perfect.
Adding to that one, I think nowadays, most of the families are demanding only washrooms are getting close to our houses. Okay, but rather than that, I strongly believe even my family also is all together. Okay, till now, we have distributed our properties, we have now difference of opinions in my family. Okay, very close to my mother and my father. Similarly, same way, I think Shalit Garu is a very big man. I cannot keep my hand on shoulder, but differentiate and you cannot separate also. That's what the beauty. All four brothers. Okay. So I think you have to give a big round of applause to make the family together. Thank you.
But today we can take it.
Thank you, sir, for an engaging presentation and for sharing valuable perspectives on contemporary approaches to technology in orthopedics. May I now invite Dr. A.V.S. Suresh to the dais to deliver his talk on the topic, Role of AI in Medicine, Opportunities and Challenges. Sir, we are honored to have you with us. Over to you, sir.
First of all, thanks for having me here. And apologies for pushing myself because I have a flight to catch. So, sure. So, it's very difficult to catch the pace after Dr. KJ has spoken. You know, with such an energy and other things, very difficult to match. So, wherever I go, when I go to deliver lectures in the technology, I feel as odd man out because I speak about medicine. When I speak in medical colleges, they feel that I'm speaking too much of technology, again, odd man out. But over a period of time, the line of demarcation is going to be blurred because most of you will be catching up with technology. So this is myself, Dr. A.V.S. Suresh. Right? So this is what I call as a knowledge matrix. What you see here is known. I know that I know these things. They are for fact. What? It is called, I don't know, but somehow it feels that this is right and I do. That's what most of the medical physicians and practitioners do. We call gut feeling or intuitions. I know that I don't know, so I ask the question, learn about it. So these four are currently done very well. The enigma or mystery is about unknown. The exploration, wherein you need to have a lot of I can say intuition, thought-provoking things, innovative thinkings, what calls it poetic thinkings. That's where the AI is going to make a difference. So that's what we call it the unknown territory, where AI, people call it black box. I'll come to that later, but this is where AI is going to make an impact. So the journey from known to unknown is accelerated by the AI is what I believe. So if I ask, when I was a student in 2016 in an institute called INSOPE, started by Dakshinamurthy, who is a classmate of APJ Abdul Kalam ji. So I was learning AI in 2016, right? So the simplest thing he told, it is nothing but mathematics. Mathematics is foundation. Then you have statistics. What they do, they help us understand patterns. Then you have AI that makes sense of those patterns so that I can understand it in a better way. Then, if those senses are taught on how to do, we call it the machine learning because it's a machine that learns. And if it can mimic us, we call it the deep learning. And then it becomes innovative. It's just like how mother teaches us. First, they will teach us for the basic skills, then small words, then grammar, then you start thinking on your own. And the journey of AI is nothing more than that. It is exactly the same from maths to generative AI, where it starts thinking on its own, and finally, if you can do it at 10x speed, you call Shakuntala Devi and other people who are called mathematical geniuses, that's called quantum computing. For those, computer works on 0 and 1, quantum works from 0 to 10. So that's exactly how speed you can see. It's million times or trillion times fast. So this is what AI is. Nothing but advanced mathematics used in a structured manner to make sense of those things. Right? So the pages, I thought there will be more pages, so I prepared this slide. We all know statistics. We use p-value. P-value tells what happened in the past. Whereas AI will tell the future. What will happen? So the word in AI is confidence. Whereas it is a p-value, that means you did a good job, is what the stats tell based upon the experiments. You are likely to do a good job is what AI is doing. So that's the difference between p-value and confidence. You call sample size in stats, you call support in the AI. You call negativity, you call specificity. Relative risk is lift. Recall, that means if I train my AI on 1 lakh people, it can recall better. That's called sensitivity. Precision, false positive, type 1, type 2 errors. All those things are nothing but statistical Singh used to tell me that, boss, whenever you do collect the data, still I have the same Excel sheet working for me. 3.8 lakh patients were entered into the Excel sheet over 26 years. And you have 5 lakh patients, myself Professor Himanshu Mehta, who is in Delhi, 5.4 million records were taken. So the entire beauty, without our knowledge, the discipline which Professor Lepi Singh gave to us is turning into gold mine here. So what we did is, we could find multiple myeloma 7% earlier than what we used to do. Just pattern recognition. Right? This is the beauty. In 2018, we came up that those who are likely to develop non-alcoholic can predict the liver functions deterioration much earlier and the renal deterioration in CKD. Okay, this comes the question of association causation. We all know that whenever the rooster crows, so the sun rises, that's association. But will it cause the sunrise? No, that's causation. That's where our logic has to come into the picture, right? If you boil the water, it gets heated, so that's causation. Whereas rooster and sun is association. So ultimately, what we could do between 2018 and 2022 is we made these algorithms practical, right? So our first solution, there were two lives. So when we started applying it, that is, assume a remote person in the village is unaware of things, just enter height, weight, and basic blood test like CBP, RFK, LFT. I can precisely tell by week 28 the mother is likely to develop hypertension. How is it possible? Data. Right? We call experience in medical language, we call data in the AI language. That's the difference. And it is not something which is not there. It is published in the NEJM and Frontiers, and it's got US patent. So whenever you innovate, like Dr. Professor Kejiri did, I want people to be innovative, but protect your innovation patent also. That's very important. Otherwise, it will be stolen. Because Western people are rich because they protect their patents, right? So the maternal health, in fact, which a team of 7 people did it. So these are the names of the people who did it. Okay, some of them are from Africa, some are from US, from Harvard, and I forgot, Baylor School of Medicine. So we all did those things, and it got patented way back in 2018. So I'm talking about those things. Then another question came. We started analyzing the asthma. No one thought about it. There is a HbA1c for sugar, diabetes. All chronic diseases need to have a long-term control. Where is it for the asthma? Most of us are smokers. We developed this. This is again a patent, which is what show that if you measure these 6 factors, apply a mathematical formula. Okay? This is a mathematical formula. You come up with a score that is going to tell whether your asthma is controlled or not. I give a small example. If you are allergic to pollen, if you go to the hospital, there is no pollen in the hospital, your spirometry is good. And if you are allergic to AC, the spirometry is bad. So both of them are wrong, right? Because the moment they do the spirometry in the hospital. So anything which is long-term have to have a long-term chronic marker. So we did those things, right? So we did one more thing, pill segregation. If you take 2 pills together, they don't work. So what is the ideal gap? We took the help of a pharmacologist, Professor Salil K. Bhattacharya. He gave us the entire database of 12,000 medicines available in the world. And then we create. It's all mathematics. Take pattern. If I just enter that, I wake up at 7 o'clock in the morning. So it will adjust all the pills accordingly. If I say I wake up at 6 o'clock and have breakfast at 7:30, it will adjust accordingly. So this pill segregation is now practical. I am not sure whether I can just make. If you can just, I made this small icon. So these are all practical working models there. So if you want, you can see those things. I don't want, because I have limited time. I'm not presenting it. Okay, just leave it. You can click it later. The PPT has all the links available. And what else we did? Right? This comes almost, it took almost 8 years for me to convince my colleagues that something we need to do in the oncology where I'm an oncologist. We did in the radiation. You give radiation, you don't know when the side effect will come, what side effect, how long they stay, what's the guarantee. With extreme precision, we can just tell that because of X amount of fat in the beam of radiotherapy, it will melt, cause inflammation, and then cause side effect after 2.5 years. Everything scientifically proven. If science is not backing up what AI is telling, I ignore it. Then comes the multimodal things for fabric neutropenia detection in oncology. I don't want to go those things. Gait analysis. I can detect fall even before and reasoning the fall also. So when you stand up, there are 3 axes. If you want to sit down, you lie down, you first sit and then lie down. So axis becomes 0. But if it happens in 3 seconds, you fell down. So gyrometry, which is there in the mobile or watch, can detect a fall. Is every fall important? No. Every vertebrate will stand up in 20 seconds after the fall. If you don't stand up, that fall is significant. So we reduce the false alarms. Is every non-recovery important? Sometimes not. If the floor is slippery, it takes some time. So the HR, that is what we call the sinus rhythm, doesn't correct itself. If the fall is very significant and medically meaningful, then the alarm goes to the caregiver. So in the remote monitoring, applying as many filters as possible is what is going to make difference in this. Then comes, I started taking the lead. Then we started doing on the mammograms. This is the most important thing. So we did a morbidity analysis in one of those things. 40 years female died in the ER. They told that the death is because of adriamycin toxin. I was not convinced. I told it cannot happen. It simply cannot happen because the patient is adriamycin dose was very low. Then we started digging. This is what actually we could see. The anti-vessel in a 38-40 years female is calcified. In those who are from the medicine background, internal mammary artery and coronary are the same, right? So what we did is we understood that breast cancer and coronary arterial disease have the same symptoms. So those are the women we started classifying the calcifications: spread, nature, size, shape, anatomy, distribution, involvement, continuous, etiology. If I apply the 28 variabilities of the calcium, I can precisely tell the final score that this particular calcium falls something like KNN. KNN means if I'm just staying with a group of 20 people, if all of them are if I just try to see the people are speaking to this in last 9 years. That's what is the beauty of those things. And something called CNNs. Computer never knows whether this is a cat or dog. It says that if the eyes are up and if the nose is like that, and if his tail is not curved, probably it is dog, otherwise it is cat. It just analyzes the pixels. So that's what called convoluted neural networks. It will just try to see, create its own layers, and then finally say whether it is a dog or a cat. So it doesn't have memory. It just works on basic principles. How we learn also on the same principles. If I just try to see and then recognize my life, there are some characters which are embedded in my mind. So that's how it's said, including the voice and other things. So we have a patterns in our neurons, the same things, that is the reason why it is called convoluted neural networks. Of our mammogram predicting the heart attack disease. That's how it requires data. So be vigilant whenever you capture the data. Let it be complete. So that not only the telemedicine or anything can have a meaningful impact in improving the patient outcomes in those things. These are all the genes which we analyze because this is a funded project, and we call something called Montague playing a match. And if you lose 2 consecutive matches, you start thinking, if South Africa beats Sri Lanka with this many runs, and if England wins against Australia, then probably we will qualify. So similarly, AI doesn't have any meaning if you don't use it, right? So ICU models for sepsis prediction, how soon the patient can be discharged or how soon the patient from the ward is likely to go to the ICU are also demystified. So these are all possible because we have been capturing the data, remind you, to 1999 when I was a PG first year, till 2026. We have the discipline of capturing the data, every data. Every day we go back, we enter in the next session. Right? Hardly 30 patients, 40 patients we see in private practice. That's not a problem. It will take 25, 30 minutes for you to enter the data. But 5 million touch points is what actually made our algorithms feasible to be implemented. So data. If you want to do something good in the AI, just ensure that you have data and it should be explainable. Okay, there is something black box or white box. So I don't go into those things. But for those who want to learn about AI, we, along with our colleagues in National Board of Examinations, started a 6-month course, which 68,000 doctors were trained. Not a small number, 68,000. It is available in the portal, National Board of Examination Medical Sciences, that teaches about the legality, that teaches about the applications, black box, white box, machine learning, CNN, everything. 40 minutes lecture, 20 minutes question answer moderated by the experts, starting from Devyani Mishra from Harvard, Rahul Kashyap from Mayo Clinics. We have best of the faculty, IASC, Fadri Albert. These are all the people who are there. Just type nbms.ai. So you will get everything available free of cost. So it is a certification program by the National Board. So with these things, I thank for giving the opportunity. I'm so sorry to push myself ahead of my previous speaker because I have a flight to catch. I have 10 minutes to answer the question.
Medical curriculum. I am Dr. Prasanna, former Secretary Medical Council.
Sir, it's very easy, sir. Just, they are much smarter than what we are.
Yeah.
Okay, so just give.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. Thank you very much, sir.
That was a wonderful talk, I think, eye-opener. Mammogram leading to prediction of MI, I think, is great.
Exactly.
Is it similar what you made? That's only your sex discrimination only working on the women welfare, mammogram.
Yeah, I mean, so we have a lady dominant team in our university. Devyani is a medical oncologist and oncologist. So she pushed for this project when I just asked the question.
So does it correlate with CT angio?
It's 100% correlation. 100% correlation. But again, CT angio is also 80-85% accurate.
Yes.
So we stopped it. We matched the CT, but we couldn't process our prediction is yes. The problem is, but if it is CAD as a disease of your interest, then the thing is CT. But if you don't want to do CT, you can still monitor the mammogram, and if the mammogram is your low risk, you can still avoid CT because we don't see blocks in this mammogram. Breast is having a different fat pattern, which is very similar to this. So ultimately, our body is having 20 different types of tissues, whether it's muscle, fat, bone, so together. So these things, if they are analyzed, each organ represents something. So with this pattern recognition, I can say where you need to focus on. You stop there, and we can't go beyond that. So a radiological biomarker is the best more to describe this. I accept that.
Thank you.
Yes, sir. So there are no questions. Sincerely thanks for giving the opportunity, to be
Thank you, sir, for your insightful and thought-provoking presentation. May I now invite Dr. B.N. Ravi Kumar, Executive. Thank you, sir. Cancer remains one of the foremost global health challenges, where prevention, timely diagnosis, and advances in treatment continue to redefine patient outcomes. The party to address the gathering on cancer care, prevention, early detection, and future directions. Sir, may I kindly request you to commence your presentation.
And we get to see some staggering numbers. 1 out of 6 worldwide deaths are because of cancer. And currently in India, we have about 27 lakh active cancer cases who are undergoing treatment. Unfortunate thing is that about 70% of all Indian patients are at least diagnosed in an advanced stage. And by 2030, 1 in 9 Indians are at risk of developing cancer in their lifetime. Coming to our own country, the top 3 cancers remain breast, cervical, as well as genital. So why is it that we get to see more number of cancer patients in the recent times? Well, the reasons are 2. One is an absolute increase in the incidence, plus crores. And over the last 20-30 years, because of advances in medications or medicines, there is an increase in average life health expectancy, and there is also proportion of patients who are beyond 70s and beyond 80s, which is higher than in the previous years. And the ever-changing lifestyle habits, which are risk factors for cancer. While the apparent rise is because of more cancer awareness, more health-seeking behaviors, better screening programs, better reporting, better diagnosis, and to some extent, information bias or visual bias, as there is wider publicity seen in the social media. So what are the risk factors for cancer? Well, age remains the single most strongest risk factor, which is not modifiable. The longer you live, the longer you are at risk for developing cancer, because with age, there is slowing down of the cellular repair mechanisms, and each cell accumulates mutations over a period of lifetime. The second thing is the genetic predisposition, where certain cancers are having genetic basis, like that of BRCA-associated cancers, which includes breast, colon, pancreatic cancers, and Lynch syndrome, where there is increased tendency for development of colorectal cancers. The other factor is the gender or sex, where certain cancers like thyroid are predominantly seen in females, and like that of females, breast cancer. Modifiable risk factors, we have seen which are strongest risk factors for development of hepatocellular carcinoma, human papilloma virus, where there is increased risk of development of cervical cancers, oral cavity cancers, and HIV, which overall alters the immune system and thereby leading to increased development of multiple cancers in the body. So what are the recommendations for cancer screening? So the latest is of this by Ministry of Health and Family, cervical cancer as well as breast cancer. In view of paucity of time, I will not be covering cervical cancer today, but we will be looking at other cancers, what needs to be done for those. Coming to oral cavity screening, it is simple oral visual examination. What we do is, whenever we encounter a patient or a person who comes to healthcare, any healthcare provider can just check for oral cavity whether there are any ulcers, red or white patches, which is nothing but erythroplakia or leukoplakia, or any swellings in the mouth. So this is called oral visual examination. Now the basis for this was a trial which was done in Kerala, which was done over a period of 10 years, where about nearly 2 lakh people have been examined at various time points. And what they have found out that whenever these pre-malignant lesions were identified, they were referred to specialists. Ultimately led to about 30% reduction in the cancer-related mortality. So what if we find any of these precursor lesions? So various medications have been tried, like that of nutraceuticals, high dose of antioxidants, vitamin A, vitamin E, retinoids, anti-inflammatory drugs, but none of them have found to be actually useful in the practice. While there was some promising effect of combination of usage of erlotinib with celecoxib, while majority of the head and neck cancers express EGFR proteins, blocking this might lead to halt in the progression of these precursor lesions into cancer. Benefit of the cancers more so in the younger patients. Now, we have got a therapeutic option for usage of HPV-associated cancers as well as pre-malignant lesions because of some inherent immune mechanisms involved in the pathogenesis, where the evidence for usage of immunotherapy, that is nivolumab, showed that there is slowing in the training. Because if we do repeated mammograms or if we do mammograms without properly fitting into the risk assessment, there is a possibility of overdiagnosis in that we tend to pick up lesions which on a mammogram might appear to be malignant, and these patients might be undergoing a lot of emotional burden, or they might also need to undergo a biopsy procedure. So all these unnecessary things can be cut down if we properly identify which patient actually needs to undergo screening. So what are the risk factors that increase breast cancer risk? That is a strong family history, age, again as I said, obesity, as well as the higher early age at menarche and late age at menopause, nulliparity, and absence of breastfeeding. So once we take a consideration of all these factors, there are various models which are available which help to categorize these patients into the various risk groups. So the highest risk is for those patients who have got genetic or hereditary association, that is the BRCA positivity, or with a history of radiotherapy to the chest. So these people have got about more than 20% lifetime risk of developing breast cancer. While the moderate risk is those who have got a family history, and average risk, the rest of the patient population. So these are certain models which are available online. We can just enter the information, the demographic data, as well as the menopausal history, whether the patients had any biopsy, atypical findings, as well as genetic markers if are available. And then based on that, we'll be able to get the risk for these patients, or for the people. So for the average risk, what is from 50 to 74 years, a 2D or 3D mammogram is the ideal screening modality. Less than 40 years of age, again, is not examination, which is done at home, or by a trained healthcare worker, which is the clinical breast examination. And it has reduced the false positive rates and the need for biopsies. So for high-risk patients who have got genetic predisposition for development of breast cancer, we usually alternate some sort of imaging with either mammogram and MRI every 6 monthly. While that for average risk, yearly or 2 yearly once mammogram is sufficient. Coming to something about colorectal cancer screening, we have got multiple screening methods which are available. The commonly used ones are the stool-based occult blood detection test. Again, it is not highly sensitive or specific. It might miss some of the tumors which are present on right side of the colon. We also got some DNA-based assays of late, which helps to identify certain precursor lesions like polyps or adenomas. And the commonly used one in practice is colonoscopy. Again, the age recommendation for these is if they have got a strong family history of colorectal cancers, then 10 years prior to the index patient is when one should initiate the screening for family members. However, age cutoff of 45 or 50 as part of general screening indication is recommended, and a colonoscopy once every 5 years is available. Coming to the lung cancer screening, again, it is only cohort-based screening for lung cancer. So the cohort includes those patients who are at higher risk of developing lung cancer. That includes 50 to 80 years of age, who have had history of smoking for more than 20 pack years and who continue to smoke or have stopped smoking but they are not crossed the period of more than 15 years. So what is suggested by this lung cancer screening trial is that you do a low-dose CT scan wherein you will be able to identify certain precursor nodules, and that is how it can alter or reduce the mortality of lung cancer. Now, why is it important that we focus on screening as well as prevention? Because with the staggering numbers of what the cancer load which we are going to see in 2040, it is highly impossible for us to cater only to the treatment aspects of it. So prevention is always better, and it is also economically not sustainable or viable for a country like ours. So we should focus on the primordial prevention, the 4 pillars of prevention: primordial, primary, secondary, and tertiary. Tertiary includes those patients who have been diagnosed with cancer, they have undergone treatment and are moving on in their life or in the rehabilitation phase. Secondary prevention is that whenever we find or have a clinical suspicion of cancer, we do something to detect them early, to prevent the disease progressing or being caught up in the advanced stages and then improve their survivals. Primary prevention, counseling in terms of diet, tobacco cessation, alcohol cessation, and HPV vaccination. So what challenges remain for us is that we lack in the policy commitment, we lack, or it's a huge manpower resource crunch which is available in terms of healthcare workers who are able to do screening for these patients. And despite that, the coverage for screening is quite low. We are able to detect cancers early in about 30% of our patients. And though in February 2026, the Government of India has started this cervical cancer vaccine rollout program, which is again on a voluntary basis but not a mandatory basis. So what we need actually is the incorporation of HPV vaccination schedule into the national event. However, when we look at the availability of whether the oncology centers, radiation, as well as other screening modalities available, it is not in proportion to what is being seen in terms of cancer incidence. So this has to change. So there are various levels where everyone can contribute to fill up this gap. At community level, we need to bring more awareness, break the myths and stigma, and then whenever at hospital levels, whenever a patient comes to us, we need to educate them. We should be able to identify the red flag signs of cancers. We should promote healthy lifestyle habits. We should also discuss about the HPV vaccination and opportunistic screening availability. And at community level, there should also be some encouragement for the ASHA workers as well as PHC staff to promote or take in more of these screening activities into the general public. So the aim for next 5 years is that we should push in through the cervical cancer vaccination, and by 2030 at least it should be more than 90-95% of all the we are using AI to analyze the mammograms so that it reduces the clinician's burden and help assist to improve the turnover rates. And currently there is also progress in terms of integration of the Ayushman Bharat as well as the other Arogyasri schemes to increase the coverage for cancer patients. So as MBBS doctors and postgraduates, you should remember that whatever specialty you walk into, in the next decade you are going to encounter cancer patients. You should have a brief awareness or brief understanding of what type of cancer it is, what treatments are, what you need to promote to the patients as well as family, healthy lifestyle habits, screening modalities available, opportunistic screening whenever possible, as well as HPV vaccination without fail. Thank you.
Good afternoon, sir. My question for you is, with the recent advances in precision oncology and immunotherapy, how can we make sure that these treatments are more accessible and available to the low-income and middle-income countries?
So, two questions to answer. One is the precision medicine. So what precision medicine is that we try to understand what genetic abnormalities, which are somatic in nature, are there, what drives these cancers, and what can be done to target these drivers. So the last 10 years, in terms of testing, when I was a postgraduate, we say, for example, in lung cancer, we used to do marker testing for about 2 or 3 genetic markers. But currently we are able to do 12 to 25 markers which drive these cancers, and we have got targets for these genetic abnormalities which drive these cancers. So in terms of testing, like that of comprehensive genomic panels, a lot more companies are available. It is more accessible, more affordable. Number 2, in terms of immunotherapy. So about 5 years back, there was only 1 or 2 companies which were US-based companies. The price was exorbitantly high, and not many patients were able to reap the benefits of immunotherapy. But currently, with Make in India strategy, we have got 3 companies, Indian companies, which are available, and the cost of immunotherapy molecule has come down to about, I would say, 70%. So it's actually 30% of the original cost, and majority of our patients are able to take with the schemes available. So we are making steady but slow progress and great progress.
Good afternoon, sir. This is Dr. Chandra from Hyderabad. My question is how HPV vaccine is not introduced into the national immunization. Is there any initiative from the Oncology Society of India to initiate HPV? And one more question is why HPV cannot be taken after 25 years? Is there any scientific reason or medical reason? Women are getting married late, so chances of sexually active also becomes late. So that is after 25 years.
Yes.
So why it cannot be taken after 25 years?
No, there is no stringent rule for that. We can take it. We can take it. Number 2, before the availability of cervical cancer vaccine, which is made by the Serum Institute, Servavac, each dose of it cost currently about 400 rupees. There was earlier US-based company Gardasil, which had 4-valent or 9-valent vaccine, which was the total cost was costing about 10,000 to 15,000. So rolling out in our country as part of compulsory immunization program was not, really in terms of cost economics was not feasible. So that's the reason why there was much lag in terms of implementation of this. But with the availability of the Serum Institute vaccine, there has been representation from Oncology Society also in terms of both data as well as proposition to incorporate it into the national immunization schedule, and I'm sure that it will come into in the upcoming years.
So what do you recommend? Is Gardasil or it is Servavac?
So we got some caveats in terms of Servavac, which is the Serum Institute vaccine. It is 4 serotypes. So in India, majority of the cervical cancers because of HPV is caused by these 4 predominant types, 85%. The 15% by the other 4 serotypes, while the Gardasil covers all of these. So once we are not able to really match for the finances, cervical cancer vaccine, Servavac is okay for us. Is okay for us.
Thank you. Nice presentation. Well covered. In your practice, how common is BRCA gene being tested prophylactically for surgery or
So we have got certain mastectomy as well as oophorectomy. Number 2, we should also discuss about the family member screening. 3, it has got implications in terms of treatment. There are certain agents called PARP inhibitors which are active in those patients who are BRCA positive. So it has got multifold implications. So it is currently in practice. The test is slightly costly, costs around 20,000 to 25,000 for the test.
Thanks.
Thank you, sir, for an enlightening presentation and highlighting the pivotal role of prevention early diagnosis and innovation in transforming healthcare. I now take the privilege of inviting Dr. Raji, Executive Committee Member, Telemedicine Society of India, Telangana Chapter, to felicitate Dr. Nikhil Patil.
Fariha, should I announce about it?
Thank you, sir. Let's move on to the next scientific session. Palliative care is at its best when expertise, compassion, and collaboration come together to support patients and their families. To share his insights on role of telemedicine in palliative care, may I invite Dr. Vijendra Gaud to kindly commence his presentation.
Good afternoon, all. So, how many of you know palliative care? Have you ever heard of the word palliative care? Very less. Okay. So, what do you understand when when you hear palliative care? Who raise hands? Yes, sir. Mike.
Yes.
So increasing the quality of life for instance.
Thank you, sir. Any comments? What comes to your mind? Increasing the quality of life, what? Sir, do you want pain management? Yes. Disability management. Okay. So let's see what palliative care does. Huh. It's okay. Mic even mic. It's okay. Mic. Thanks. So, palliative care, as I said, improves the quality of life. So, palliative care is basically for the patients and their families suffering from the terminal ill diseases. So, terminal ill diseases like cancer, HIV, AIDS, or Alzheimer's. So, whatever the disease which does not have a cure, so but we can care. So, in those diseases we give palliative care. So, palliative care it's a symptomatic approach. We don't treat the disease, but we just treat the symptoms of the disease. So it is not disease-directed treatment. It is symptomatic approach to the disease. Okay. So palliative care is it can be started early or late. So there are two types of palliative care. It is the early palliative care and next is the late palliative care. So early palliative care is as soon as the disease is the radiation or the chemotherapy, patient can be started on the palliative. So there are two types. So early palliative care, other one is the late palliative care. So the role of telemedicine comes in the late palliative care because most of the times when the patient is getting the active
So palliative care is not like any other disease. So for the acute disease or chronic disease, when a patient comes, we write the prescription and ask him to come after. We write the prescription and ask him to come after 1 week or 2 weeks. So, but here the patient is for the long goes through the emotional stress, spiritual distress, and also the financial burden. So, so palliative, the need of palliative care is increasing in India. So because of the aging population and also the increasing of the non-communicable diseases, especially like cancer. So palliative care is received by less than assistance to come out of the home on the bed. And also the patients require assistance to come out of the home on the bed. Long-term care, maybe it is for weeks, months, or sometimes even years. So, as I said, palliative care deals with the physical symptoms, emotional, spiritual, and even years. So, as I said, palliative care deals with the physical symptoms, emotional, spiritual, and palliative care addresses this also. So, palliative care addresses this also. So, this is can be addressed by the telemedicine. So, here, and you can get treated at the local physician or the local hospitals. Once they go to the local physician, they may be less. Once they go to the local physician, they may be less trained in the palliative care. So they may not get the expert. So they may not get the expert care, or they may be financial burden also, because once they go to the local doctor, they start doing investigation again from the CT to CT scan. For example, patient goes with an abdominal pain, so he may do the CT scans also, which is not required. So this is what we can address to the telemedicine. So what is required? So to deliver care in the home or to the patients, to remotely to give telemedicine services, what is required? There are only two things. One is electronic medical records. So doctor or the hospitals can have the electronic medical records. So patient details, both the demographic and the treatment details, he can have in the EMRs, and the patient can have the phone. So nowadays, everyone is having a smartphone. So with these both things, we can treat the patient remotely. Next. So the solution. So the burden is so much, and a patient is faces so much difficult to travel. For example, we are here. For example, patient has to come from the Nizamabad. Patient is having pain and he has to travel like 200-300 kilometers. So can we address these things? Yes, we can address. How? This is through the online consultation. So as I said, there are already patient records. So we can, whenever the patient faces a problem, so we can give the treatment. So in the palliative care, we give the anticipatory medication. For example, patient is having pain or breathlessness, nausea, vomiting. So whenever a patient comes to the palliative care OPD, we give them the anticipatory medications. Once, for example, patient calls in the middle of the night, so we can pick the call and we can ask that patient is having pain, what should I do? So usually this cancer patient won't be touched by the local physician. Usually we call PAS. So they won't touch this patient because of fear of death. So if this patient dies, he comes on to me. So nobody touches these patients. So these patients have to travel long distances to get treatment for the small elements also. So for this, how we can address this? We can go through this anticipatory medication. So whenever the patient calls, we can tell whether we give this, for example, morphine. So whether breakthrough medication of the morphine is taken or not, or if it is not working, what next medication can be given. So for the same, like vomiting also. For example, patient is having vomiting, so we try with one anti-vomiting. It's not, you can go with the second one. So like that, we can treat the patient. So he need not to travel. So in palliative care, most of the times patient family member comes to the OPD. So they are unable to come out of the home or from the bed. So most of the times patient attendant comes to us. So at that time we ask the family member to call the patient. Mostly to the video call. So we use the video call and we see the patient, speak with him and prescribe the medication. Tailored care to the patients, tailored care to each and every patient. So to the multidisciplinary team, so we can address, as I said, physical symptoms like pain, nausea, vomiting, emotional and spiritual, financial burden. So we can reduce the burden. So here palliative care is a teamwork, not only the doctor. So health counselors, dietitian, so all people will do this. Patient burden can be reduced. The care burden can be reduced. The caregiver burden will be reduced because every time patient develops a complication, he need not to rush to the hospital or call someone for the assistance. So these can be addressed by telemedicine. So healthcare system also, the burden on the healthcare system can be reduced. Unnecessary hospitalizations can be reduced and care continuum will be there. Any questions?
Thank you very much, sir. I am Dr. Srinivas Rao, Professor of Anesthesia in this hospital. I heard in America they started a concept called perioperative PSH, perioperative surgical home, where telemedicine has got an important role. It is by virtual counseling of getting operated patients before, after surgery, post-operative, so that it can reduce the length of the stay. Such concepts are there in our country. Thank you.
I am not aware.
I'm Professor studying Maheshwara Medical College. So we are giving that care through e-surgery module. So it is a telemedicine module where it is developed by Ministry of Health and Family Welfare. So to decrease the burden on the hospital, because then ESI has a lot of burden, patient burden. So to get beds quickly so that the beds can be available for the other patients, we are giving that care, perioperative and post-operative surgical care. And only review consultations are being done, not the mandatory consultations, which needs to be seen by a surgeon.
Thank you. And another concept is in the UK, they have started orthogeriatric concept.
Please wait on
This is a rehabilitation and pre-rehabilitation and subsequent management. This is getting very popular. Where in an institution, they have developed a separate ward where multidisciplinary teams will visit, especially geriatric patients with unstable fractures and chronic rehabilitative diseases. Is it necessary? Here, is it helpful for our country also?
Yes, sir. Surely it will help. So patient need not to travel. And if they are getting treatment at home, it's good.
No, this is not at home. In the hospital itself, they are creating orthogeriatric concept. Orthogeriatric concept, especially for the elderly patient with hip fractures and long-standing debilitating fractures. And this goes, and it involves multimodal team, where anesthesia, surgeon, nurses, and dietitian, and physiotherapists are all involved. So it is a multi-departmental model. This helps a lot, in my opinion.
Yes, sir. Yes, sir.
Any questions? Any comments? Yeah. Sir, mostly palliative care patients, they start early. So, we have a discussion, family members. Goals of care are discussed in detail. So, once they accept the goals of care, there are no complications. If they are not if they are not accepting the goals of care, so then only the complications rise. And then here the problem is with the morphine availability of the narcotics. So even to the telemedicine, we advise them medication. The problem comes with the availability of the narcotics. So they have to travel again hundreds of kilometers to get the morphine or fentanyl or methadone. So there is a limitation.
Thank you, sir, for an inspiring presentation on the importance of multidisciplinary collaboration and virtual care in delivering holistic, patient-centered palliative services. I now take the privilege of inviting Dr. Shankar, Executive Committee Member of Telemedicine Society of India, Telangana Chapter, to felicitate Dr. Vijendra Gaur. With the very theme of today's conference. It is my honor to invite Dr. Santosh Kumar Kaliti to address the gathering on telemedicine for community healthcare services. Sir, the podium is yours.
A very good afternoon to all. Good afternoon. Dr. Krishna Radha is calling. Someone can just answer this. Yeah, so I'm the last man standing between the lunch and you people. So it's a difficult task to keep you engaged. And first of all, congratulations to Maheshwara Medical College for organizing such a wonderful topic of AI in healthcare, and of course the partner Telemedicine Society of India. Thank you, Mr. Ramchandra and Dr. Krishna Rao for having me here. Thank you so much. Yesterday night I had to, I had reached Hyderabad at 1:30 after all these NMC discussions and all that. And of course, Maheshwara Medical College is one of those beneficiaries that you got a hike of how many 100 seats? So congrats, big round of applause. And also go to healthcare. And I'm sure by this time, most of you might already know that half the job of our radiologists is already being done by AI. One of my very good friends who was, I used to work for an organization called Access Health International, and our office was in, ISB in Gachibowli. And very recently I met this young lady who used to work with us. Subodh, you might be knowing her. Her name is Laina Emmanuel. And this girl is basically a techie. And she used to work with us. And recently I bumped into her and I came to know that she and one of her neurology friends, they together did a startup on MRIs of brain. And recently, she was invited by Narendra Modi ji for top 100 AI startups in India. And they got an investment of more than $100 million into their company. Big round of applause for Laina and her team. So, a lot of things are happening, and if India and Indians can do this healthcare AI startups, I think we can show a lot of live data. We have seen in Facebook, Instagram, LinkedIn, and 100 other Googles and YouTubes, right? A lot of people are proud that I am a YouTube, what is that? You have a platinum and gold and all that, right? But then, of course, he's making billions and he's giving you millions. But then I think it's time that Indians start building their own AI platforms. So I will quickly briefly touch upon a couple of areas where AI can play a very big role and has already started to play a role. And this is the first presentation where I'm using AI. I have used AI in building this presentation, and two of my students have helped me. So you can see there is no photograph which was used. It's all AI. And I'm sure you're all using AI tools to build your presentations. So we'll go to the... Can I use this? Yeah? Yeah. How do I... Okay, thank you. So, from early screening to smarter healthcare delivery, I think Vijayendra was touching upon palliative care. There are 100 such areas where AI can really help us. Very recently, we were in discussions at Gangaram Hospital in Delhi about the genetics department. And for a whole genome sequencing to be done in genetics, sometimes it is taking 30 to 45 days. And if large AI models are used, this whole genome sequencing can be done in one day. So that is the power of AI. But of course, you require that kind of investment. But this is where a lot of genetics, a lot of predictive medicine, a lot of preventive medicine, AI is going to change the dimension of healthcare, and also how doctors use AI. Probably how we used to use a stethoscope or an ultrasound or an X-ray. In future, doctors have to use AI. So we cannot get averse to AI. We have to survive with AI. We have to know how to use AI. And I think that is where you need to be smarter and one step ahead. So most of the students who are in, especially now MBBS and in your post-graduation, must start using some of these AI healthcare tools which are readily available, which I'll be presenting. Now we all know that huge burden of disease because of the size of the denominator. The population itself is so huge. 100. You could see that above 18 years of age, 22% of the population is diabetic and 26% of the population is hypertensive. And if you have an intersection set, at least 30% would be having both diabetes and hypertensive above the age of 18. So imagine out of 3 crores, if your 18 years above is around 2 crores, 30% of the population has both hypertension and diabetes, which is how much? 30% of 2 crores is how much? 60 lakhs? 60 lakhs is the denominator. And in our National Health Mission program, we have a very interesting national program for NCDs. In that national program of NCDs, we could do only one thing, that we could go and test them whether they have diabetes or not. But we could not monitor them. Are they taking medication on time? Are they going for tests on time? Is the medication working? Do they need higher? Predict someone's health. How does this happen? So I think we have a great deal of burden of disease, and this can be $1 billion. So out of this $1.6 billion, how much of He ran a very good healthcare tech company in US, and it is a unicorn. 6,000 crores that we are seeing day to day. Shortage of specialists in rural area. I mean, in urban areas, for example, a state like Andhra Pradesh has 1.6 doctors per every 1,000 people. Telangana has 0.7 doctors per every 1,000 people. Chhattisgarh has 0.4 doctors and Bihar has 0.3 doctors per every 1,000 people. There's a huge difference. It have 1.1 doctors per 1,000 people, but a district like Sitamarhi, which is on the border of Nepal, will not even have 0.1% of doctors per 1,000 people. So 1 doctor per 10,000. Same way, recent districts like Bastar, Sukma, Narayanpur, which have been freed from Naxalites, they don't have even 1 doctor per 10,000 people, but Raipur might have 1 doctor per 1,000 people. That is the kind of disparity we are seeing. And forget about doctors. The even more scariest part is audiologists, optometrists, emergency technicians. These people are even more scarce resources. So how do you address these things? Shortage of specialists, delayed diagnosis. You come to medical college in a government hospital, my OPD is on Wednesday and I come back to the OPD only on Wednesday. So you come and see me today, sheets are torn. So how can we address these things? And rising disease burden, and we have all just understood about how hypertension and diabetes is there in Telangana. All of which lab should I believe? There's so much of inaccuracy in reporting itself. And limited access to quality healthcare in remote areas, which we are already discussing with places like even Adilabad, Etur Nagar, even in our Telangana, where we have high percentage of doctors, we are seeing NABH quality and compliance requirements. So how each of these things AI can play a role. So this is one of the very interesting things which I would request each one of you, if you have a good mobile phone or a tab, please do download some of these apps. Some of these apps are absolutely free of cost. Cure AI, one of the best healthcare AI companies in the world today. It's an Indian company, and you see they have built one of the best chest X-ray interpretation for TB. The world over, now this is being used. It is being used in Africa. It is being used in Southeast Asia, Far East Asia. Cure AI is going to become one of the friendly platform for understanding whether a patient has got TB or not by looking at the X-ray imaging. So this is a wonderful tool. Similarly, Deep Tech AI is also trying its level, and with the kind of population base, I came to understand recently that Niramai has already screened more than 6 lakh mammography images. So I think it is going to have one of the very robust predictive platforms in the world. Similarly, of course, Unit Insight, iCAD Profound and Cure AI have also got, but I would say that Niramai is one of the best, breast cancer screening AI platform. Similarly, for cervical cancer, I would rate Serve AI is one of the best in diagnosis, and it is very, very cost effective. Hardly they are charging 10 rupees for giving the results and predictive analytics. And I think in within 1 hour, your patients would be, happy that they will, the moment you give the photograph, even the image of the cervix and also the tissue, that AI in their, whatever equipment that they are building. Again, in pathology, sick tuple is very nice. If you oncology smears, any cancer or pathology smears, I think their prediction is very good. Very recently, some of these technologies have been used by Government of Andhra Pradesh, and Government of Andhra Pradesh has also given some prizes, and one of those companies is from Hyderabad. Similarly, medical records. E-care is doing exceptionally well. Many new tools, but e-Sanjeevani, I would say, is one of the very strongest platform. Even for neonatology, you have very good tools which we are using in now Nilofer Hospital also. So you can remotely monitor. So these sort of tools are very interesting. MediBuddy is also very nice. You can look at MediBuddy and you can, it is also very helpful, especially for remote monitoring. Now, you have a if you go into the Koita Center, which is working on all this documentation, most of the NABH documentation is now automated. So you can use all these tools which are now again free of cost being given by NABH. So medical colleges, wherever we are working, Cure AI has been exceptionally wonderful, especially for imaging, radiology, and I would suggest that your hospital softwares can be automated very easily. I would suggest that small things, very small thing. For example, AIG has built an AI tool. And the AI tool which AIG has built is one of the best. If you have a patient with health insurance in your hospital and today they have been discharged, this burden of bureaucracy, AIG has started something in their hospital management system which has doctor's notes and doctor's summary can be written in 20 minutes, 30 minutes, but usually doctor's summary itself takes 6 hours. Because finally to go to the doctor. The AI is doing the doctor's summary and finally the doctor can read it and say whether everything is fine or not before the doctor writes the summary. This small innovation of AIG has brought down the bed occupancy, unnecessary bed occupancy rate, which you cannot charge after discharge in AIG hospital. So very wonderful way of innovation. So small innovations make a lot of difference. I hope Maheshwara Medical College and Telemedicine Society of India together, I think will help in innovations. Some of the innovations are for areas like Bastar. Currently, I am working in Chhattisgarh for improving the primary healthcare systems. So if you can do all use it, and you can all understand that it is also very easy to build an AI tool for your sphere. We run a chain of human milk banks and we see that a lot of mothers have at least 400 questions. The total number of questions, FAQs, are 400. And we have developed now on AI platform in more than 14 languages. Mothers can be helped through this AI platform in antenatal, postnatal, and also, in the first 1,000 days of life. So this is something which we are building for breastfeeding and lactation management. So minute is so minute thing you can pick up and you can build your AI platform and that will become tomorrow a world leader. So many people who are here, I would request all of you to wear an entrepreneurship hat and build your own AI tools, and each doctor can build your own AI tool, and that way I think the whole world will benefit, and more importantly our Indians must build the AI with our own data. Thank you so much.
Thank you, sir, for imparting your expertise to the audience on expanding role of telemedicine in strengthening community healthcare and improving access to quality medical services. I now take the privilege of inviting Dr. Prasanna Raj, Dr. AIIMS Delhi, to felicitate Dr. Santosh Kumar Kraleti. Thank you, sir. Ladies and gentlemen, we have now come to the final session before lunch. Let us have the same enthusiasm and engagement that has marked this conference so far. Artificial intelligence is redefining the way we diagnose, treat, and deliver healthcare. May I now invite Dr. Shreya Chattopadhyay to deliver her lecture on role of artificial intelligence in medicine, opportunities and challenges. I now welcome our speaker.
Again. Thank you. So hello. So good afternoon, everyone. And trust me, I know you all are very hungry. Me too. To come here, I started my day 3 a.m. in the morning. So I will take only 10 minutes. And I would love to cover all these things within these 10 minutes of time. Generally, I take sessions for the doctors and mainly for the different AI tools because I am from a complete technology background and I believe we can read all these things, but we should know how to use the tool in proper places. So generally my topic are AI in research pathology. I took in Safdarjung Hospital with the AIMS and ICMR doctors. I took it with a different state society of critical care and India Arthroplasty Society and all. And also my course is going on the tools. But today I'm not here to take the tools because it will take time. So I will give normal, just one, normal things, the normal discussion. So when I started taking my lecture long back, because we are Microsoft Tier 1 partner also, so long back I started taking. That time ChatGPT and all the other tools, they just, people just got to know about that. So general one question I have faced again and again, that is AI will take the role of the doctor, the job of the doctor and all. So do you think it is a good question? I took it in another way. It is a wrong question. Rather the question is that are we ready to accept this AI? That is the main thing. It's not visible. Right? Okay, sure. Thank you. So, I want to tell you one thing. Healthcare doesn't need more AI. Ecosystem. So, that is the most important because we know all these things in AI. But are we ready for this AI? That is the main thing. So, this is the message I want to give you for the today. Anything? Okay. So this is here. One side there is a patient, another side there is healthcare service hospital. So we are now making the bridge of AI in the process. It is not completed. So there are 4 pressures. Now every clinician in this room, they know the pressure of too many patients, the pressure of too few specialists, the pressure of too much data and too little time. So, do you think all this happened because of AI? Because every time we blame on AI, but all this happened not because of AI. It was there already. And I think AI is the only technology who can solve these things in a very good way. Because AI can just convert your prescription, that is unstructured to structured data. Now, if AI can convert your prescription to the structured data, you can easily search on the data. So it is unstructured to structured data. AI can do that. It can save your prescription in Excel form as well. AI can summarize the thing, whatever you want. You can just upload all the documents, it can summarize. It can predict the patient risk. We have made one AI software where it is actually predicting the risk of sepsis. So AI can do all these things. We have already made all these models. So AI can actually solve these things. Now I am coming to, according to me, I am just doing AI in a very simple word. So this is 4E. One is enhance. So AI is enhancing the capabilities of the healthcare profession. Another is expand. So everything is accessible. So AI expands the access. Third is equalize. So rural and metro area, they equalize by AI. And the fourth and most important is empowerment of patient. Now patient as a partner. AI is not motivating the patient for challenging the doctor. AI is motivating the patient to collaborate with the doctor. Think about one situation. In previous days, patient did not know about what is HbA1c. So they came to the doctors, they asked the questions, what is that? Why the score is high for me? Now they ask only the actual question, how I can reduce this HbA1c. So AI is actually empowering the patient. Now another thing which I believe is that people often actually tell me AI is dangerous, AI is hallucinating, AI is doing the mistake. Yes. But do you think this healthcare sector only dependent on the technology? No. Healthcare sector built on trust. And that's why we have to think, we have to make some platform where we can, it will depend on the ethics, validation, bias testing, privacy and accountability. Then only we can over the challenges of that. Now coming to the sixth pillar. So every stakeholder in the room, because I believe telemedicine society is not only for the doctors. So there are stakeholders of government, doctors, scientists and all. So we have to ask that AI ready clinicians, AI ready patients, AI ready hospitals, AI ready industry, AI ready government and AI ready data. So doctors must become AI ready because not by trusting AI blindly, right? So they have to know when to trust AI, when not to trust. Can they actually get when AI is hallucinating? I am giving you one example, one very big company of insurance. They have taken data of one particular person who has some surgery of kidney stone. So naturally there it is written, stent is removed. Now that particular insurance company cancelled his insurance because they have written that you have heart disease. Heart is perfectly fine. They have given all the data to AI. AI was hallucinating. Stent means AI thought it is because of the heart disease. They did it and finally he or she signed. In the past, it was dependent on the evidence-based medicine. Now it is data-driven medicine, and future it will be intelligence-based medicine. Thank you. It is intelligence-based medicine. Now take an example. Some patient came with a chest pain. So previously doctors gave prescription according to their experience. Then ECG and all these things come, so they are given the prescription depending on the data. Now what is intelligent based? Now whenever the patient will come with this, so AI will tell it is risky, do this and do that measurement. So that is intelligence based. But see, one good thing is that in this intelligence based medicine, the doctors is already there. We can never replace the doctor also. So that is the most important part of that. Now imagine India in 2035. So think about every PHC connected, every after workers AI enabled, every specialist accessible remotely, every hospital interoperable, and every citizen owning a digital record. So if everything is in its place, now the big question is that can we do it responsibly? Because in case of AI, whenever we are using AI, we should know about the responsible usage of AI also. Again, I am going to the question, will AI replace the doctor? The answer is no, because AI can replace uncertainty, AI can replace the delay, AI can replace, not any GPT cannot hold the hand of a patient. So the future of healthcare will not belong to those who simply use AI. It will belong to those who know when to trust it, when to question it, and how to collaborate with it. Technology may diagnose disease, only humanity heals people. Thank you. Any question? Sure.
I think very well articulated.
Thank you.
Well articulated. AI healthcare tools are different from other AI tools.
Yes, 100%.
Probably the over hospitality or other things they are fine. But for healthcare, they have to be responsible, they have to be time-tested,
yes,
they have to be ethical, and they should go through the rigor before it is used for the larger population.
Not only that, they cannot upload any patient data on the cloud.
Absolutely.
Before this. So we have to be careful. Rather, I take second on that one.
So very, very well said. And even in India, currently CEDESCO is giving permissions. But CEDESCO also does not have enough internal intelligence of how to deal with AI healthcare tools. So we are very, very early to build a regulatory framework for healthcare AI technologies in India. And I think mature AI healthcare technologies probably will happen in a year or two. Once even at the governance level and regulatory levels, we have a framework how to regulate and how to understand them better. But one interesting thing that you made, see currently again I'm going back, I'm working in Chhattisgarh, they are very, very closely at the ground level. They have 70,000 ASHA workers, the highest in any state, across any state, highest. The whole ASHA started from Chhattisgarh and Bhutan. Bhutan is spread of the rural domain. So 70,000 ASHA workers can here we are building AI platform, a small app, in which she get prompts, as you rightly said. So a mother is having pain, what she should do. The mother is having anemia, how she can guide. So it should be like a guidebook, it should be like a prompt. When we used to do medicine, we used to have big Robbins Pathology, we used to have a handbook of Robinsons. Now we used to have a big Davidson, we used to have a handbook of Davidson also. So AI will be useful for every level, like this handbook, and it will help. So I think this is a wonderful tool, and as you rightly said, we need to use it, we need to know how to
use that. Exactly.
We need to know how to use it, and then I think
responsible use of this. Thank you so much, sir. Thank you.
Ma'am, I have a question.
Please.
Thank you for the reassurance that doctors are not replaceable.
Thank you.
My question is regarding something you already mentioned in your PPT as well. AI give a wrong opinion and a patient's harm. Who ultimately is responsible and how do we protect ourselves? Or what are the medical legal or ethical aspects of this?
No, if patient is doing on its own thing, then they are not responsible. The doctors are not responsible. But as for example, sometimes the doctors are giving personal bot to use for the patient. Now, what's the problem is that
he or she did not check the body's sensitivity. Now, while using this board, if the patient is getting wrong data or wrong suggestion, then the doctor is responsible for that. Because according to DPDP Act, it is saying in the beginning, the human is responsible and man should be intermediate. This is same for bank as well. So the responsibility is that. So that's why I am asking, it was asked for whether we are really seeing find out the anticipation, the bias and all these things. That is the most important thing. We do not need more AI, but we need more responsible instead of AI. But everyone can behave that. Thank you so much.
Thank you, ma'am, for presenting on the opportunities and responsibilities that accompany AI in modern medicine. I now invite Dr. Namrata, Assistant Director, Rajarajeshwari Institute of Medical Sciences, to felicitate Dr. Shreya Chattopadhyay. Thank you, ma'am. We have now reached the lunch interval. Delegates are cordially invited to join us for the business lunch, where conversations and collaborations may continue in an informal setting. The conference will reassemble at 2:30 p.m., following which we shall commence scientific session 2, focusing on digital health, mental health, and the future of healthcare. Thank you, and we look forward to welcoming you back for the afternoon session. I request you all to please be seated back in the auditorium by 2:25 p.m. the latest. Thank you.
But with these both things, we can treat the patient remotely. Next. So, solution. So, the burden is so much, and a patient is faces so much difficult to travel. For example, we are here. For example, patient has to come from the Nizamabad. Patient is having pain, and he has to travel like 200-300 kilometers. So, can we address these things? Yes, we can address. How? This is through the online consultation. So, as I said, there are already patient with us. So, we can, whenever the patient faces a problem. So, the solution. So, the burden is so much, and a patient is faces so much difficult to travel. For example, we are here. For example, patient has to come from the Nizamabad. Patient is having pain, and he has to travel like 200-300 kilometers. So, can we address these things? Yes, we can address. How? This is through the online consultation. So, as I said, there are already patient with us. So, we can, whenever the patient faces a problem, so we can give the treatment. So, in the palliative care, we get the anticipatory medication. For example, patient is having pain or breathlessness, nausea, vomiting. So, whenever a patient comes to the palliative care OPD, we give them the anticipatory medications. Once, for example, patient calls in the middle of the night. So, we can pick the call and we can ask that patient is having pain, what should I do? So, usually this cancer patient won't be touched by the local physician, usually we call PAS. So, they won't touch this patient because of the fear of death. So, if this patient dies, he comes on me. So, nobody touches these patients. So, these patients have to travel long distances to get treatment for the small elements also. So, for this, how we can address this? We can go through this anticipatory medication. So, whenever the patient calls, we can tell whether we give this, for example, morphine. So, whether breakthrough medication of the morphine is taken or not, or if it is not working, what next medication can be given. So, for the same like vomiting also. For example, patient is having vomiting. So, we try with one anti-vomiting. It's not, you can go with the second line. So, like that, we can treat the patient. So, we need not to travel. So, in palliative care, most of the times, patient family member comes to the OPD. So, they are unable to come out of the home or from the bed. So, most of the times, patient attendant comes to us. So, at that time, we ask the family member to call the patient, mostly to the video call. So, we use the video call and we see the patient, speak with him and prescribe the medication. So, we use telemedicine even in OPD. So, through telemedicine, we can tailor care to the patients, tailor care to each and every patient. So, to the multidisciplinary team, so we can address, as I said, physical symptoms like pain, nausea, vomiting, emotional and spiritual, financial burden. So, we can reduce their burden. So, here palliative care is a teamwork, not only the doctor. So, health counselors, dietitian, so all people will do it. So, through the multidisciplinary team, we can address their problems. Yes. So, here, what are the benefits using the telemedicine? So, patients, they need not to travel long distances. So, the care can be taken from the comfort of their homes. So, financial burden can be reduced. So, caregiver burden will be reduced because every time patient develops a complication, he need not to rush to the hospital or call someone for the assistance. So, these can be addressed by telemedicine. So, healthcare system also, the burden on the healthcare system can be reduced. Unnecessary hospitalizations can be reduced and care continuum will be there. Any questions?
Thank you very much, sir. I am Dr. Srinivas Rao, Professor of Anesthesia in this hospital. I heard in America they started a concept called perioperative PSH, perioperative surgical home, where telemedicine has got an important role. It is by virtual counseling of getting operated patients before, after surgery, post-operative, so that it can reduce the length of the stay. Such concepts are there in our country. Thank you.
I am not aware.
I'm professor in Maheshwara Medical College. So we are giving that care through e-surgery module. So it is a telemedicine module where it is developed by Ministry of Health and Family Welfare. So to decrease the burden on the hospital, because when ESI has lot of burden, patient burden. So to get beds quickly so that the beds can be available for the other patients, we are giving that care. Perioperative or post-operative surgical care, and only review consultations are being done, not the mandatory consultations, which needs to be seen by a surgeon.
Thank you. And another concept is in the UK, they have started orthogeriatric concept.
Please wait on
This is a rehabilitation and pre-rehabilitation and subsequent management. This is getting very popular. Where in an institution, they have developed a separate ward where multidisciplinary team will visit, especially geriatric patients with unstable fractures and chronic rehabilitative these things. Is it necessary? Here, is it helpful for our country also?
Yes, sir. Surely it will help. So patient need not to travel. And if they are getting treatment at home, it's good.
No, this is not at home. In the hospital itself, they are creating orthogeriatric concept. Orthogeriatric concept, especially for the elderly patient with hip fractures and long-standing debilitating fractures. And this goes, and it involves multimodal team, where anesthesiologists, surgeons, nurses, and dietitian. This helps a lot, in my opinion.
Yes, sir. Yes, sir. Any questions? Any comments? Yeah. Sir, mostly palliative care patients, they start early. So, we had a discussion, family members. Goals of care are discussed in detail. So, once they accept the goals of care, there are no complications. If they are not if they are not accepting the goals of care, so then only the complications strikes. And then here the problem is with the morphine availability of the narcotics. So even to the telemedicine, we advise them medication. The problem comes with the availability of the narcotics. So they have to travel again hundreds of kilometers to get the morphine or fentanyl or methadone. So there is a limitation.
Thank you, sir, for an inspiring presentation on the importance of multidisciplinary collaboration and virtual care in delivering holistic, patient-centered palliative services. I now take the privilege of inviting Dr. Shankar, Executive Committee Member of Telemedicine Society of India, Telangana Chapter, to felicitate Dr. Vijendra Gaur. I invite Dr. Akhila, Secretary, Telemedicine Society, to felicitate Dr. Vijendra Gaur. Thank you, ma'am. Our next scientific lecture resonates closely with the very theme of today's conference. It is my honor to invite Dr. Santosh Kumar Kaliti to address the gathering on telemedicine for community healthcare services. Sir, the podium is yours.
A very good afternoon to all. Good afternoon. Dr. Krishna Radha is calling. Someone can just answer this. Yeah, so I'm the last man standing between the lunch and you people. So congratulations to Maheshwara Medical College for organizing such a wonderful topic of AI in healthcare, and of course the partner Telemedicine Society of India. Thank you, Mr. Ramchandra and Dr. Krishna Rao for having me here. Thank you so much. Yesterday night I had to, I had reached Hyderabad at 1:30 after all these NMC discussions and all that. And of course, Maheshwara Medical College is one of those beneficiaries that you got a hike of how many 100 seats? So congrats, big round of applause. And also the Women's College also has, I think 150 seats. Yeah, again, hearty congratulations. So good news after good news. So many things happening. So, but the bigger question is, what will happen to all these doctors after they get manufactured? So that is also $1 million question. So let's also discuss sometime about healthcare and human resources. But I would like to bring before you a couple of things, especially what AI can do to healthcare. And I'm sure by this time, most of you might already know that half the job of our radiologists is already being done by AI. One of my very good friends who was, I used to work for an organization called Access Health International, and our office was in, ISB in Gachibowli. And very recently I met this young lady who used to work with us. Subodh, you might be knowing her. Her name is Laina Emmanuel. And this girl is basically a techie, and she used to work with us. And recently I bumped into her, and I came to know that she and one of her neurology friends, they together did a startup on MRIs of brain. And recently she was invited by Narendra Modi ji for top 100 AI startups in India, and they got an investment of more than $100 million into their company. Big round of applause for Laina and her team. So a lot of things are happening, and if India and Indians can do this healthcare AI startups, I think we can show a lot of light to the world, because most of the companies are using our data and our people don't know how to use our data. And we usually are shy creatures and we let the other people use our data. We have seen it Facebook, Instagram, LinkedIn, and 100 other Googles and YouTubes, right? A lot of people are proud that I am a YouTube, what is that? You have a platinum and gold and all that, right? But then, of course, he's making billions and he's giving you millions. But then I think it's time that Indians start building their own AI platforms. So I will quickly briefly touch upon a couple of areas where AI can play a very big role and has already started to play a role. And this is the first presentation where I am using AI. I have used AI in building this presentation, and two of my students have helped me. So you can see there is no photograph which was used. It's all AI, and I'm sure you're all using AI tools to build your presentations. So we'll go to the. Can I use this? Yeah. How do I? Okay, thank you. So, from early screening to smarter healthcare delivery, I think Vijayendra was touching upon palliative care. There are 100 such areas where AI can really help us. Very recently, we were in discussions at Gangaram Hospital in Delhi about the genetics department. And for a whole genome sequencing to be done in genetics, sometimes it is taking 30 to 45 days. And if large AI models are used, this whole genome sequencing can be done in one day. So that is the power of AI. But of course, you require that kind of investment. But this is where a lot of genetics, a lot of predictive medicine, a lot of preventive medicine, AI is going to change the dimension of healthcare, and also how doctors use AI. Probably how we used to use a stethoscope or an ultrasound or an X-ray. In future, doctors have to use AI. So we cannot get averse to AI. We have to survive with AI. We have to know how to use AI. And I think that is where you need to be smarter and one step ahead. So most of the students who are in, especially, for example, just Telangana. Telangana state has in our NFHS SITS data, National Family Health Survey SITS data, you could see that above 18 years of age, 22% of the population is diabetic and 26% of the population is hypertensive. And if you have an intersection set, at least 30% would be having both diabetes and hypertensive above the age of 18. So imagine out of 3 crores, if your 18 years above is around 2 crores, 30% of the population has both hypertension and diabetes, which is how much? 30% of 2 crores is how much? 60 lakhs? 60 lakhs is the denominator. And in our National Health Mission program, we have a very interesting national program for NCDs. In that national program of NCDs, we could do only one thing, that we could go and test them whether they have diabetes or not. But we could not monitor them. Are they taking medication on time? Are they going for tests on time? Is the medication working? Do they need higher or lower medication? We don't have any data. एक बार कर लिया पेपर के ऊपर टेस्ट को लिख दिया बस हो गया. So how do we predict someone's health? How does this happen? So I think we have a great deal of burden of disease, and this can be dealt by using this wonderful platform of AI, where AI can help us in predictive analytics and lot of other aspects. So 1 in 28 women have breast cancer, and cervical cancer is even bigger. We have 1 lakh diagnostic labs, but all of them are in cities. None of them are in villages. So how do people in the village, how do they deal with this diagnostics? So this is the size, and the size of AI market is $1.6 billion. So out of this $1.6 billion, how much of this money will go to the West, to the US markets, European markets, and how much will be within the Indian market? Who is going to rule this healthcare AI market? I think it is quintessential that Indians do this innovation. And I think we need to look at that angle as well. Did I move 2 slides or 1 slide? Yeah, thank you. So these are the things which are happening. Thank you. So you can see TB screening, breast cancer, cervical cancer, medical imaging. Extensively, we have done a lot of work in medical imaging. Digital pathology. One of my very good friends in Hyderabad, they have started AI for cervical cancer, pathology, and even for oncology. Wonderful work is happening. Electronic medical records. NABH. For the first time, a non-doctor has become the head of National Accreditation Board for Hospitals. You all know. You know who's the guy? He ran a very good healthcare tech company in US, and it is a unicorn. 6,000 crores. And he set up a special fund for supporting AI in healthcare. His name is Koita. And the Koita school is the kind of work at the center. We think that non-doctor has become, but that guy is having more understanding in medical data and data analytics than what we have. Probably epidemiologists can probably challenge these guys. But these are some of the challenges that we are seeing day to day. Shortage of specialists in rural area. I mean, in urban areas, for example, a state like Andhra Pradesh has 1.6 doctors per every 1,000 people. Telangana has 0.7 doctors per every 1,000 people. Chhattisgarh has 0.4 doctors and Bihar has 0.3 doctors per every 1,000 people. There's a huge difference. And if you go to Chhattisgarh or Bihar, you see that Patna might have 1.1 doctors per 1,000 people, but a district like Sitamarhi, which is on the border of Nepal, will not even have 0.1% of doctors per 1,000 people. So 1 doctor per 10,000. Same way, recent districts like Bastar, Sukma, Narayanpur, which have been freed from Naxalites, they don't have even 1 doctor per 10,000 people, but Raipur might have 1 doctor per 500 people. So there's huge disparity in doctors. So how do we address this? And once the doctor has come to Maheshwara Medical College, he wants to go to Hyderabad. He would not even go back to Sangareddy. You ask him to go and practice in Sangareddy. No, sir, I want to go in Hyderabad. Gachibowli, high-rise buildings. So I'll stay there only. He will not even want to go to Nampalli now. He wants to go to only Gachibowli. Everyone wants to come to Gachibowli. So Gachibowli has 10 doctors per 1,000 people, and Sangareddy might have 1 on Wednesday. So you come and see me today, do the test which I prescribe, and come back and show me on next Wednesday. 1 week. How will this work? In this age, will patient like to come back after 1 week for showing his test? Or is it not economic wage loss? Is the patient not suffering that he comes back here and goes back and again comes back? So how are we going to address these things? So delayed diagnosis, documentation burden, file, rehta hai, kabhi nahi rehta hai. And you don't know whether the dates, when it has happened, some of the case sheets are torn. So how can we address these things? And rising disease burden, and we have all just understood about how hypertension and diabetes is there in Telangana. All over India, that is a bigger burden that we are seeing. Variability in diagnostic accuracy. Just yesterday, one girl, she came and showed some reports to me. So this lab is showing that I have prolactin level this much, and this lab is showing prolactin level this much. This lab is showing testosterone level this much. This lab is showing testosterone level this much. A girl who is suffering from PCOD. 2 labs, both of them NABL accredited, are showing so much wide variance. The patient is going mad. What's happening? Which lab should I believe? There's so much of inaccuracy in reporting itself. And limited access to quality healthcare in remote areas, which we are already discussing with places like even Adilabad, Etur, Nagaram, even in our Telangana, where we have high percentage of doctors we are seeing, it can play a role. So this is one of the very interesting things which I would request each one of you, if you have a good mobile phone or a tab, please do download some of these apps. Some of these apps are absolutely free of cost. Cure AI, one of the best healthcare AI companies in the world today. It's an Indian company, and you see they have built one of the best chest X-ray interpretation for TB. The world over, now this is being used. It is being used in Africa. It is being used in Southeast Asia, Far East Asia. Cure AI is going to become one of the largest AI companies in healthcare. And they have a very, very user-friendly platform for understanding whether a patient has got TB or not by looking at the X-ray imaging. So this is a wonderful tool. Similarly, Deep Tech AI is also trying its level best. CAD, 40B and ROKAI. All these 4 companies are from India. And all these 4 companies are working extensively on tuberculosis. And some of them are working on genome level. ROKAI is working at the genome level. So I would suggest, if anyone who is doing the general medicine or in pulmonary medicine, you can look at this tool. Very interesting tools. Similarly, breast cancer, I think I would rate Niramai as one of the best breast cancer AI platforms. And with the kind of population base, I came to understand recently that already mammography images. So, cancer screening AI platform. Similarly, for cervical cancer, I would rate Serve AI is one of the best diagnosis, and it is very, very cost effective. Hardly they are charging 10 rupees for giving the results and predictive analytics. And I would seriously suggest that all gynecologists, all obstetricians and oncologists, I think it is a very, very easy tool. And I think in within 1 hour, your patients would be, happy that they will, the moment you give the photograph, even the image of the cervix and also the tissue that is being predicted. Very, very beneficial to the women. So, and cervical cancer burden is bigger than breast cancer burden in India. So I think it's very cost effective. Similarly, AI medical radiology and imagiology, Cure AI is again doing very, very good in this. Not just for chest X-rays, but MRI brain, CT brain. Most of these predictions are very, very fast. Similarly, Siemens and GE, both these companies have also inbuilt AI in their, whatever equipment that they are building. Again, in pathology, SIG-tuple is very nice. If you oncology smears, any cancer or pathology smears, I think their prediction is very good. Very recently, some of these technologies have been used by Government of Andhra Pradesh, and Government of Andhra Pradesh has also given some prizes. And one of those companies is from Hyderabad, which is working on laboratory automation. Similarly, medical records. ECA is doing exceptionally well in medical records. Of course, Practo has also started, but then ECA I find is very, very nice. You can look at these tools. Telemedicine and remote patient monitoring. Of course, there are many, many new tools, but eSanjeevani, I would say, is one of the platform. Even for neurology, very good tools which we are using in now Nilofer Hospital also. So you can remotely have a lot of AI technology which is coming into emergency and ICU care. For example, all your patient monitoring systems, they are linked up to an AI tool. And if there is any change in your multi-para monitor, it is sending you, alerts, and the critical care physicians, they can immediately respond. Thank you. Yeah. So, in NABH now, we are using a lot of AI tools for clinical documentation, patient safety, infection control, quality indicators, incident reporting, audit and compliance, and hospital operations. So, if you go into the Koita Center, with all this documentation, most of the NABH documentation is now our medical colleges, wherever we are working. Cure AI has been exceptionally wonderful, especially for imaging, radiology, and I would suggest that your hospital softwares can be automated very, very easily. I would suggest that small things, very small things. For example, AIG has built an AI tool, and the AI tool which AIG has built is one of the best. If you have a patient with health insurance in your hospital and today have been discharged, burden of bureaucracy, AIG has started something in their hospital management system which has doctor's notes and doctor's summary can be written in 20 minutes, 30 minutes, but usually doctor's summary itself takes 6 hours because finally to go to the doctor. The AI is doing the doctor's summary and finally the doctor can read it and say whether everything is fine or not before the doctor writes the summary. See, unnecessary bed occupancy rate which you cannot charge after discharge in AIG hospital. So very wonderful way of innovation. So small innovations make a lot of difference. I hope Maheshwara Medical College and Telemedicine Society of India together, I think will help in innovations. Some of the innovations are for areas like Bastar. Currently, I am working in Chhattisgarh for improving the primary healthcare systems. So, if you can do help those primary care patients who are in the tribal areas, so Ladakh, you can have a platform here, and the patients can be screened, and you can help. So, lot of things can be helped by both telemedicine and AI and automation. So, but one of the best public health is Cure AI, Niramai, and SIGTUPL, and Vadhwani Foundation is also working on Vadhwani AI for tuberculosis elimination. So these are some of the wonderful innovations which are happening in the public health sphere. So thank you so much, and I have shared this presentation with the team. You can all use it, and you can all download some of these apps which are available, and the moment you start downloading, you can understand that it is also very easy to build an AI tool for your sphere. We run a chain of human milk banks, and we see that a lot of mothers have at least 400 questions breastfeeding and lactation management. So minute is so minute thing you can pick up, and you can build your AI platform, and that will become tomorrow a world leader. So many people who are here, I would request all of you to wear an entrepreneurship hat and build your own AI tools, and each doctor can build your own AI tool, and that way I think the whole world will benefit. And more importantly, our Indians must build the AI with our own data. Thank you so much.
Thank you, sir, for imparting your expertise to the audience on expanding role of telemedicine in strengthening community healthcare and improving access to quality medical services. I now take the privilege of inviting Dr. Prasanna Raj, Dr. AIMS Delhi, to felicitate Dr. Santosh Kumar Kraleti.
Good afternoon, everyone. Respected Dr. Krishna Rao, Senior Director, Maheshwara Medical College and Vice President, Telemedicine Society of India, dignitaries, distinguished faculty, colleagues, researchers, students, and honored guests. It is both a privilege and pleasure to be here today to share my thoughts on a subject that I believe will define the next era of medicine. Healthcare is experiencing one of the most profound transformations in its history. We are moving beyond an era where medicine was largely reactive and hospital-centered into one that is predictive, personalized, connected, and increasingly intelligent. The title of my presentation is Healthcare Beyond Boundaries. The boundaries I refer to are not only geographical, they include the traditional boundaries between hospitals and homes, physicians and technology, prevention and treatment, and even between earth and space. Today, three powerful forces are converging to redefine healthcare. The first is artificial intelligence, which is transforming vast amounts of health data into actionable clinical insights and enabling earlier, more accurate, and more personalized decisions. The second is human performance science, a discipline deeply rooted in aerospace medicine, which shifts our focus from simply treating disease to continuously optimizing human health, resilience, and performance. The third is telemedicine, which has evolved far beyond virtual consultations to become a connected healthcare ecosystem capable of delivering expert care regardless of distance. Throughout this presentation, I will demonstrate how these three domains are converging to create what many describe as Healthcare 5.0. A healthcare system that is intelligent, patient-centered, technology-enabled, and driven by continuous physiological intelligence. As an aerospace medicine specialist and human performance scientist, I have had the unique opportunity to work in environments where continuous monitoring, predictive analytics, and human-machine collaboration are essential for mission success. Interestingly, many of the principles that have safeguarded pilots and astronauts for decades are now finding applications in everyday healthcare. Today, I invite you to look beyond the traditional boundaries of medicine and explore a future where healthcare becomes more proactive, equitable, and human-centered than ever before. But before we discuss where healthcare is heading, it is important to first understand why transformation has become an absolute necessity. What are the global challenges driving this change? And why can we no longer rely on the healthcare models of the past? But before I go through my presentation, the standard disclaimer, whatever I speak today is in my personal capacity and my organization has nothing to do with this. So before we discuss the future of healthcare, we must first understand why transformation is no longer optional, it is essential. Healthcare systems around the world are facing unprecedented pressure. We are witnessing an aging population, an epidemic of chronic diseases, rising healthcare costs, workforce shortages, clinician burnout, and persistent inequalities in access to quality care. According to the World Health Organization, non-communicable diseases now account for nearly 3 out of every 4 deaths globally. Rising, while the number of people over the age of 60 is expected to double by 2050. At the same time, healthcare expenditure continues to rise, yet millions of people still lack timely access to specialist care. The fundamental challenge is that our healthcare systems were designed for the 20th century, when medicine focused primarily on treating acute illness. Today, we face a very different reality, one that demands continuous care, early detection, personalized treatment, and seamless coordination across healthcare settings. These challenges are interconnected, and solving them requires more than increasing infrastructure or manpower. We need a smarter, more proactive approach, one that leverages artificial intelligence, digital connectivity, and continuous physiological monitoring while keeping people at the center of the care. This is why healthcare is undergoing one of the most significant transformations in its history. So, if the traditional model is no longer sufficient, what does the next generation of healthcare look like? Let us explore the concept of Healthcare 5.0, a human-centered ecosystem where technology empowers clinicians, patients, and health systems to deliver safer, smarter, and more personalized care. Now, having understood why healthcare must change, the next question is, what should the future look like? The answer lies in what we call Healthcare 5.0, a model where technology is not the center of healthcare, but an enabler of better, more human-centered care. At the heart of Healthcare 5.0 is the patient. As you can see here, surrounding the patient is an intelligent ecosystem powered by artificial intelligence, continuous physiological monitoring, telemedicine, precision medicine, and human performance science. These technologies work together to deliver the right care at the right time in the right place. Artificial intelligence transforms data into clinical intelligence, helping clinicians make faster and more accurate decisions. Continuous monitoring through wearable sensors enables early detection of physiological changes, shifting healthcare from episodic treatment to proactive prevention. Telemedicine extends specialist expertise beyond hospital walls, making quality healthcare accessible regardless of geography. An equally important pillar is human performance science, an area where aerospace medicine has led for decades. Instead of waiting for disease to occur, we continuously monitor and optimize human performance, resilience, and readiness. These same principles are now being translated into mainstream healthcare. Finally, Healthcare 5.0 embraces precision medicine, recognizing that every patient is unique and that treatment should be tailored to an individual's genetics, physiology, lifestyle, and environment. Together, these pillars represent a fundamental shift from reactive to predictive care, hospital-centered to patient-centered healthcare, and one-size-fits-all medicine to personalized, data-driven care. Healthcare 5.0 is not simply about adopting new technology. It is about creating a healthcare system that is smarter, safer, more accessible, and ultimately more compassionate. If Healthcare 5.0 is the vision, then artificial intelligence is one of the most powerful driving forces. But AI is not here to replace clinicians. It is here to enhance human capability. Let us explore how AI is becoming the healthcare professionals' most valuable clinical partner. Artificial intelligence is undoubtedly one of the most transformative technologies in modern medicine. However, the most important message I want to emphasize is this: AI is not here to replace clinicians. It is here to augment human expertise. Healthcare today generates an enormous volume of data, from electronic health records and medical imaging to genomics, laboratory results, and wearable devices. No individual clinician can analyze all of this information in real time. AI bridges this gap by rapidly identifying patterns, recognizing subtle abnormalities, and generating clinically meaningful insights that support better decision making. We are already seeing its impact across healthcare. AI assists radiologists in detecting cancers earlier, helps cardiologists identify arrhythmias from ECGs, supports pathologists in analyzing digital slides, predicts clinical deterioration in intensive care units, and personalizes treatment recommendations based on individual patient characteristics. Beyond diagnosis, AI is also transforming clinical workflows. By automating documentation, summarizing patient records, identifying drug interactions, and prioritizing high-risk patients, it reduces administrative burden and allows clinicians to spend more time where it matters most, with their patients. As an aerospace medicine specialist, I see a striking parallel with modern aviation. Advanced aircraft continuously analyze thousands of flight parameters and provide pilots with real-time decision support. Yet, the pilot always remains in command. Similarly, AI should function as a trusted clinical co-pilot, providing intelligence, while clinicians provide judgment, experience, empathy, and accountability. The future of healthcare will therefore not be built on artificial intelligence alone. It will be built on human intelligence amplified by artificial intelligence, creating safer, smarter, and more personalized healthcare for every patient. While AI is transforming how we diagnose and manage disease, the next frontier extends even further. Medicine is beginning to shift its focus from simply treating illness to continuously optimizing health, resilience, and performance. This brings us to a concept that has long been central to aerospace medicine: human performance science. Medicine has traditionally focused on diagnosing disease and treating illness. However, the next frontier in healthcare is not just about helping people recover, it is about helping them perform at their best. This is the essence of human performance science. As an aerospace medicine specialist, this philosophy has shaped my professional journey. In aviation and space medicine, our patients are often perfectly healthy individuals: fighter pilots, astronauts, and aircrew. Our responsibility is not simply to keep them disease-free, but to ensure they remain physiologically and cognitively capable of performing safely in some of the world's most demanding environments. Human performance is influenced by multiple interconnected domains: cognitive function, physical fitness, emotional resilience, behavioral habits, and the surrounding environment. Advances in wearable technology, biosensors, and AI now allow us to measure these parameters continuously and analyze them intelligently and personalize interventions before performance declines or disease develops. This represents a fundamental shift in healthcare from reactive treatment to proactive optimization. Rather than waiting for illness to occur, we continuously assess health, identify subtle physiological changes, optimize performance through targeted interventions, and monitor outcomes in real time. The exciting development is that principles pioneered in aerospace medicine are now finding applications across mainstream healthcare. Continuous physiological monitoring is improving care in ICUs, supporting chronic disease management, enhancing rehabilitation, promoting healthy aging, and even optimizing the well-being of healthcare professionals themselves. Ultimately, the goal of human performance science is simply but powerful: to preserve health, enhance resilience, and maximize human potential throughout life. As we increasingly integrate AI, wearable technologies, and predictive analytics into healthcare, we are moving beyond treating disease. We are creating a future where medicine continuously helps people live healthier, safer, and higher performing lives. Many of these principles have been refined over decades in one of the world's most demanding operational environments: fighter aviation and human space flight. The question now is, what can modern healthcare learn from aerospace medicine? Let us explore how lessons from cockpit are now transforming patients' care on ground. One of the unique perspectives I would like to share today is how aerospace medicine is helping shape the future of healthcare. For decades, aerospace medicine has focused on keeping healthy individuals, fighter pilots, astronauts, and aircrew safe and mission ready in environments where even a small physiological error can have catastrophic consequences. In these settings, waiting for symptoms is simply not an option. Instead, we continuously predict, monitor, and prevent. This philosophy is now finding its way into modern healthcare. The same principle used in aviation, continuous physiological monitoring, early warning systems, simulation-based training, human factors engineering, and decision support are increasingly being applied in ICUs, emergency medicine, chronic disease management, and patient safety. For example, in aviation, onboard system continuously monitor both the aircraft and the pilot, providing alerts before a situation becomes critical. Similarly, hospitals are beginning to use AI-powered early warning systems that detect subtle physiological changes and identify patients at risk of clinical deteriorations hours before traditional methods. Another valuable lesson from aviation is the importance of teamwork and human factors. Concepts such as crew resource management, developed to improve flight safety, have now become integral to surgical safety, emergency medicine, and critical care by improving communication, leadership, and decision-making under pressure. As someone involved in fighter aviation physiology and human performance, I see this as an exciting convergence. The operational principles that have protected pilots and astronauts for decades are now helping create healthcare systems that are safer, smarter, and more proactive. Ultimately, the future hospital will increasingly resemble a mission control center, continuously monitoring patients, predicting risk, supporting clinicians with intelligent decision-making, and intervening before deterioration occurs. That is the true contribution of aerospace medicine to the future of healthcare. If prediction and prevention are the goals, they depend on one critical capability: continuous physiological monitoring. Thanks to wearable technologies, biosensors, and artificial intelligence, we are moving from occasional healthcare management to continuous physiological intelligence. Let us see how this transformation is redefining healthcare. One of the greatest limitations of traditional healthcare is that we only assess patients at isolated points in time: a clinic visit, a hospital admission, or an annual health checkup. Yet our physiology is dynamic, changing every second of every day. Today, advances in wearable technologies, biosensors, AI, and cloud connectivity, these are transforming these isolated measurements into continuous physiological intelligence. Modern wearable devices continuously monitor heart rate, ECG, oxygen saturation, respiratory rates, sleep quality, physical activity, stress levels, and even subtle physiological trends that may signal earlier stages of disease. Instead of waiting for symptoms to appear, we can now detect changes before they can become clinically significant. However, data alone are not enough. The real power comes when AI converts this continuous stream of information into meaningful clinical insights. AI can identify hidden patterns, predict deteriorations, generate early warnings, and support timely intervention, shifting healthcare from reactive treatment to proactive prevention. This concept has long been central to aerospace medicine. During flight operations and space missions, we continuously monitor physiological parameters to detect fatigue, hypoxia, cardiovascular strain, or cognitive decline before they compromise performance. The same philosophy is now being applied to patients with chronic diseases, those recovering at home, and even healthy individuals seeking to optimize their well-being. Ultimately, continuous physiological monitoring allows us to understand health as a dynamic process rather than a series of isolated events. It enables earlier diagnosis, personalized interventions, better outcomes, and a truly preventive model of healthcare. The future of medicine will not be defined by how often we see our patients, but by how continuously we understand their physiology. Continuous physiological intelligence becomes even more powerful when distance is no longer a barrier. By combining these technologies with digital connectivity, healthcare can reach patients wherever they are. This is the promise of telemedicine beyond consultation, care without boundaries. Telemedicine has evolved far beyond video consultations. Today, it represents a connected healthcare ecosystem that brings healthcare to the patients rather than requiring the patient to travel to healthcare. By integrating telemedicine, wearable technologies, remote monitoring, AI, and interoperable digital health platforms, we are creating a model of care that is continuous, personalized, and accessible regardless of geographical location. This transformation spans the entire healthcare continuum, from health promotion and disease prevention to specialist consultations, tele-ICUs, chronic disease management, post-op follow-up, rehabilitation, and even palliative care. Patients can now be monitored in their homes while remaining continuously connected to their healthcare team. The greatest impact of telemedicine is in improving healthcare equity. It enables specialist expertise to reach rural communities, remote islands, disaster-affected regions, offshore installations, military deployments, and in the future, even lunar and Mars missions. Geography should no longer determine the quality of healthcare a person receives. From an aerospace medicine perspective, this concept is very familiar. During aviation and space missions, physiological data are continuously transmitted to mission support teams, allowing experts to guide clinical and operational decisions remotely. The same principles are now transforming civilian healthcare through connected care and virtual healthcare systems. Ultimately, telemedicine is not simply about technology, it is about improving accessibility, continuity, efficiency, and patient-centered care. It reduces unnecessary hospital visits, enables earlier intervention, supports better chronic disease management, and strengthens healthcare systems while keeping the patient at the center. Healthcare is no longer confined to the walls of a hospital. It is becoming connected, intelligent, and truly without boundaries. Now, as healthcare becomes increasingly digital and connected, another important question emerges. How do we ensure that technology enhances rather than replaces clinical expertise? The answer lies in human-AI teaming, where artificial intelligence functions as a trusted partner, empowering clinicians to make better decisions while preserving the human touch that remains at the heart of medicine. AI is often discussed as if it will replace doctors. I believe that is a wrong conversation. The real future of healthcare is not human versus AI. It is human with AI. AI excels at analyzing massive data sets, recognizing subtle patterns, predicting clinical deteriorations, and generating evidence-based recommendations within seconds. However, it cannot replace the qualities that define great healthcare professionals: clinical judgment, ethical reasoning, empathy, communication, and compassion. The greatest value is achieved when clinicians and AI work as a team. AI continuously analyzes, AI helps detect. This partnership is already transforming healthcare. In radiology, AI helps detect abnormalities that might otherwise be overlooked. In cardiology, it assists in interpreting ECGs, predicting cardiovascular risk. In ICUs, AI-powered early warning systems identify patients at risk of deterioration, allowing earlier intervention. In precision medicine, AI integrates genomic and clinical data to support personalized treatment strategies. As an aerospace medicine specialist, I see a strong parallel with modern aviation. Advanced fighter aircraft continuously monitor aircraft systems and provide pilots with real-time decision support. Yet, regardless of how sophisticated the technology becomes, the pilot always remains in command. AI in healthcare should function in exactly the same way, as a trusted clinical co-pilot, enhancing human capability while leaving responsibility and accountability firmly with the clinician. For this partnership to succeed, AI must be ethical, transparent, explainable, secure, and free from unacceptable bias. Above all, healthcare must remain human-centered. The future of medicine will not be determined by the intelligence of machines alone. It will be determined by how effectively we combine the computational power of AI with wisdom, compassion, and experience of healthcare professionals. Together, they create healthcare that is safer, smarter, and more personalized than either could achieve alone. We have now explored three pillars driving healthcare 5.0: AI, human performance science, and telemedicine. Let me conclude by bringing this together into a single vision of the future where technology, human expertise, and compassionate care converge to create a truly connected healthcare system without boundaries. Healthcare is no longer evolving through a single innovation. It is being transformed by the convergence of AI, human performance science, telemedicine, and continuous physiological intelligence into what we recognize as healthcare 5.0. At the center of this transformation is not technology, it's the patient. Every digital innovation, every AI algorithm, every wearable sensor, every telemedicine platform exists for one purpose: to improve human health and enhance the quality of life. Healthcare 5.0 represents a shift from reactive to predictive care, from episodic treatment to continuous health management, and from one-size-fits-all medicine to truly personalized care. Instead of treating disease after it develops, we will increasingly predict risk, prevent illness, optimize human performance, and intervene earlier than even before. As an aerospace medicine specialist, I find this transformation particularly exciting because these principles are not entirely new for me. Aerospace medicine has spent decades developing systems that continuously monitor human physiology, predict performance degradation, and support critical decisions in high-risk environments. Today, these same concepts are moving from the cockpit and spacecraft into hospitals, homes, and communities across the world. However, technology alone will never define the future of medicine. Success will depend on ethical leadership, robust governance, data security, interoperability, multidisciplinary collaboration, and above all, preserving the trust between patients and healthcare professionals. If we embrace innovation responsibly, we have an unprecedented opportunity to create healthcare that is more accessible, more equitable, more efficient, and more compassionate than ever before. My vision is simple: a future where every individual receives the right care at the right time in right place, supported by intelligence technology, but always guided by human values. Healthcare without boundaries is no longer a distant aspiration. It is already becoming a reality. The responsibility to shape that future belongs to all of us. Thank you. The future of medicine will not be defined by artificial intelligence alone. It will be defined by how wisely we combine technology with humanity, innovation with compassion, and science with purpose. Together, let us build a future where healthcare truly knows no boundaries. Thanks again. Any questions? I'm open to questions. Sir? Okay.
No, sir, please wait for the felicitation.
Thank you, sir, for the insightful presentation. May I now have the privilege to invite Dr. Rajiv Bandaru to felicitate Dr. Ajay Kumar. Yes, sir.
Very inviting section. And then, what do you think that this particular thing, how do we start? You have told me about the Paradigm area. What would be the best step-by-step thing to bring this particular thing to the unserved areas? It could be rural, it could be whatever. So how we can, what would be step-by-step? Practically, you talked about the whole scope of the thing. How do we make it, how do we execute?
So very it's a very good question, sir. It's a dilemma world over, how to connect distant areas with metros, bigger cities, where these healthcare facilities are available, at times more than required, and there are places where absolute minimum are also not available. It has been spoke by earlier speakers also. So this inequality in healthcare accessibility, this is what I talked about in Healthcare 5.0. The telemedicine, the human performance science, and ability to continuously monitor is likely to shift this balance. And in my personal opinion, I believe this will start from tier 3 cities, distant areas, rural areas. Unfortunately for us, as an Indian, we are more tolerant and accepting to changing technology. We are more adaptable. That's been seen through data. So I am confident in our lifetime we will see these changes happening dramatically and very fast pace. I always draw a simile between acceptance of UPI payments, digital payments. Now it has reached to the farthest corner of the country. In similar manner, the wearable devices, the healthcare performance monitoring will be connected through telemedicine to all these healthcare centers where geographical location will no more matter, because through the data your healthcare parameters can be monitored. And even today it's happening in bigger cities, in Western countries. The experts are seeing your reports in New York and giving you treatment advice in New Delhi or in Patna. It is happening even today. So these inequalities will be leveled off in coming times with the better accessibility of wearable devices, cheaper so that it is accessible to everyone, and the availability of internet. That is also important, connectivity. So internet connectivity, once it is available, the data is faster. All these things the dots will get interconnected. And once this gets interconnected, the healthcare 5.0 that I have discussed will be a reality. And it is happening in front of us in a small bits and in our lifetime. That is my thanks.
Thank you, sir. Digital connectivity is redefining healthcare by ending seamless diagnosis and consultation of care across distances. It is my privilege to invite Mr. Ravi Amle to deliver his lecture on diagnostic level connected care, healthcare platforms for teleconsultations. Sir, may I kindly request you to take the podium. As we are working within a limited time frame, the next session will have a time limit of 10 minutes.
Good afternoon, everybody. Thank you for the opportunity to the management of Maheshwara Hospital, Dr. Kuntara, the chairman, the dean, and the Telemedicine Society of India. I'd like to give a little bit of a backdrop as to where I come from in this space. My professional foundation in telemedicine has been with NASA, developing an algorithm that could communicate or transmit information in real time across hybrid networks. We came under a clinical trial under the was able to connect into a mobile surgical unit in Ecuador where a person was undergoing a top-down operation. So what did we have at the time? We had 4 USB-based devices that measured weight, temperature, pulse oxy, and NRBP. So we obviously shipped that out to the clinical trial. And to our confound, it became a life-saving clinical trial. So she was able to save the life of the person. Otherwise, the chairman of the Indian Space Research Organization one day saying that Dr. Rangan and 11 of his colleagues were going to come out to Milpitas, California to see a live demo of what we had done. So we had no clue how this happened. And then, we couldn't help ourselves. We called Chuck Brown, was a project manager at NASA, and said, hey, we got this call like this. He said, no, man, I made that call. Then we realized that NASA, certain divisions of NASA, works with the Indian Space Research Organization almost on an hourly basis every day. The level of collaboration was amazing. So one thing led to another. Dr. Rangan and the level of scholarly capable leaders, I'll be very quick. He saw what we had done. They said, well, you apply against an RFP that we are rolling out for a national telemedicine network. We did. We got it. We connected 400 district hospitals with 200 village resource centers connecting to 62 multi-specialties. So by virtue of which we were awarded with the Pan-African Telemedicine Project, where the first company I started in this space, is running in about 48 African countries under a contract between the African Union, the WHO, and the Indian government. So, this was all under the leadership of Dr. Kalam. I mean, what a tremendous visionary, and God bless his soul. So, a lot of learnings have come in, how accessible we need to be, how intuitive we need to be, how user-friendly we need to be, how much we need to keep this solution simple, and how it can be, how it needs to be really patient-centric, physician-centric, and healthcare ecosystem-centric. So with these learnings, I started a company called Sakina, my AI analytic ginger. Everything has a healthcare flavor to it. So what do we do here? How can we virtualize the provider by the patient successfully? How can we be very portable and affordable by doing that? So what we offer today at production level is a 6-participant diagnostic level multimedia platform that supports 10 measurements at this time. But the scalability factor becomes very important. For the individuals that are technically oriented, this is a platform, especially our space scientific officer here, who have a tremendous respect for all the work that they do. It is a vendor-neutral platform, wherein it is device agnostic, it is communication agnostic, it is storage and distribution agnostic. So we should be able to plug in any third-party biometric device, any third-party EMR, EHR, HMS, works on wired, wireless, cellular, SATCOM, and is cloud neutral for storage and distribution. Why again? Well, we have to work with local economies. So if you're in a specific socioeconomic demography, how can we work with local products? How can we attach ourselves or integrate to existing hospital and healthcare systems so that we are able to minimize or optimize the initial cost of ownership, right? Now, from discussions that I've happened so far, nobody gave me a job. They said, it's a self-funded project, foreign between care resource program, we have some jobs for you. And look where we are today. But how do we use AI? What is responsible AI? Whether we are developing or generating or building agentic AI. How do we keep the human in the loop? How can we demarcate between the very important in AI, regulation is another area that is very important in AI. So when we build intelligent systems, how do we aid the provider? How do we provide information that we aid the provider to supply to the patient? I like to stress this because, we live in a cloud or a ChatGPT world today. Anything that we want to do, we just go ChatGPT, we go cloud, and whatever it says is God's truth. Very dangerous, right? So the human mind should be able to factor in and rationalize the information that is coming out. Is that appropriate now? With that, we are currently running pilots at a few All India Institute of Medical Sciences to build up credibility, so to speak, 5 of them matter of fact. And we landed a very prominent rural healthcare system in rural Maharashtra recently, and I'm very excited to share that. And that will be a significant springboard for Sakina. So having said that, I'm open to questions. We look forward to building the next level of excitement. The physician network, the clinical network are our champions. Our job is to do the best job that we can so that we build the most effective value-added tools. Thank you. If you don't have any more questions, we all have a wonderful afternoon now. Sure. Yeah.
How we can apply artificial intelligence into the equipment management? How do we equip the equipment management?
good question. We are not in the business of developing equipment, but if you were to answer your question, if you're a hospital system that has a set of medical devices, you're a hospital system that has its own EMR, EHR, HMS. If you were to give me information that I require to integrate your systems and workflows and devices into my platform, that is my job to do it, to optimize your initial cost of ownership, and in other words, work with your healthcare infrastructure. Sorry. There is a perspective for any given system, as long as there are providers that need to provide our delivery to patients, we want to be here. Thanks. Thank you very much.
Thank you, sir, for such an insightful presentation. May I now respectfully invite Mr. Uma Mahesh, Treasurer, EC Member, Telemedicine Society of India, Telangana Chapter, to felicitate Mr. Ravi Ambe. Thank you, sir. Medical innovation continues to redefine the scope of reconstructive surgery, significantly enhancing both function and quality of life, particularly among the elderly. To speak on this evolving field, may I now invite Dr. R.V. Kotteshwara Rao to deliver his lecture on plastic surgery and latest innovations, reconstructive surgery and geriatric care. Sir, I request you to commence your presentation.
Slide. Sorry. You can use the slide.
Good evening to. So you can see how actually they were uniting, dividing, uniting and dividing. And they were formed by 5, 6, 7, 8 and T1. This is the basic anatomy. And how 8 and T1 will control the hand. So there will be overlap, definitely. But broadly they were divided into these categories. And what about the sensory distribution? It will start from here, 5, 6, 7, 8, T1, of course here it is T2. T2 will go not into the brachial plexus. This is a different thing. But that's how the sensory distribution. If you know the motor and sensory distribution, if you can analyze, you can identify the level of injury and the at the root level or trunk level or division level or how many roots were involved. You can assess all those things by simple clinical examination if you know this picture. And what are the patient demographics? So, grossly these will be two. Adults, how this is the lifestyle problem. The speeding vehicles. We used to call all these injuries in our days pulsar vehicle injuries because it has highest speeding thing and least safety things. So all the brachial plexus patients were young patients between 20 and 30, and they used to come and we used to examine. And first question is how you got injured. And a speeding two-wheeler fell down and I got injured my upper limb. That's it. The other is pediatric. These are obstetric brachial plexus injuries in a difficult labor where breech presentation happens first, and then while the head is stuck there, they'll try to do the maneuvers, our dear obstetricians. Unfortunately, when head is forcefully separated from the shoulders, the plexus will stretch and there will be stretch injuries starting from the neuropraxia to the root avulsions. That is the other modality, and they are called as obstetric brachial plexus injuries. Grossly, we will classify them into upper plexus where there is C5 and C6. Of course, I have seen only exclusively C5 injuries also, and then extended upper plexus injuries, 5, 6, 7 will be involved, 3 roots will be involved. And then T1 hands, apart from the T1, all other roots, 4 roots were injured. And in the PAM plexus, everything was injured. And in lower plexus, only C8, T1 were injured. So when these things will happen, lower plexus injuries typically will happen when a person falling from a height, holding something, like falling from the tree and holding a branch, or falling from a building and holding the sunshade, something like when he is falling and holding something, the stretch will start from below. So the lower roots will be involved. Like already I have discussed how upper plexus will be injured. Head is separated forcefully from the shoulders. Head will be separated like in a speeding vehicle accident or even OBPAs. And the remaining is its severity, the extent. If they are severe enough, whatever started from the clumpies can extend up to C5, or if it is severe enough, whatever started from the C5, that is Erb's policy, can extend up to the T1. So that is PAM plexus injuries. Suppose if in these patients there can be multiple level of injuries, which you have to, which are very difficult to predict in clinical settings, because once the proximal root is injured, you think that you have found the injury and you will repair it, and you will miss the distal injury. So MR neurogram will be gold standard to rule out all the multiple sites of injuries. Of course, MRI also can predict MRI brachial plexus. ENMG will give you predictive value, electroneuromyogram, and CT myelography actually root avulsions from the spinal cord. If you want to know exactly, CT myelography is the best. MR neurogram or MRI will give pseudomeningocele in most of the cases, but that is not conclusive. Pseudomeningocele is not the conclusive. So you found a patient and then you have investigated them. What are your strategies to treat these patients? So, at most important is what we have seen in many cases. What will happen is patient will come to you very late. So what is late exactly in these things? So in these things, timing of the presentation of the patient to you is very, very important. And any patient who presented as early as possible, you can monitor, you can diagnose, you can identify level of injuries and all those things. And then if it is not preganglionic avulsions, what is preganglionic avulsions? Basically avulsions from the spinal cord. That is preganglionic avulsion. If it is preganglionic avulsion, you can start treatment straight away. In all post-ganglionic injuries, depending on the level of investigations and depending on the level of identifications, you can wait up to 3 months because neuropraxia is the most common injury in the brachial plexus injuries. In neuropraxia is a completely recoverable problem. It's a conduction block. there is no structural deformity, there is no structural injury. So you can wait. That's how, in majority of cases, we will end up treating the patient beginning from the 3rd month completion or so. So that is the best time. So you can rule out the neuropraxia and you can start as early as possible. Why to start early at all? Whenever nerve injuries happen, nerve is a transmitter like an electrical wire. The signal comes from the brain and reaches to the destination target muscle. The fascicle will carry the signal, and at the end there will be neuromuscular junctions. Those neuromuscular junctions will transmit the signal actually to the target, that is muscle. So the neuromuscular junction decay will start from the day of injury itself. And they will reach a critical stage. Means beyond that stage, the available number of neuromuscular junctions cannot just somewhere. So if a axon is growing 0.5 mm per day, if the injury is at the neck level and the target is in the hand, how many years it will take to reach that place? It's almost 2 feet. So 2 feet will take a lot of time. 600 into 2, 600 mm into 2. So it's not. So that's how the age of the patient is very, very important in predicting the result. Of course, another is the level of injury. It's as I have discussed, preganglionic, postganglionic, root level, trunk level, division level, cord level, anywhere. Depending on that, the proximal the injury, the worse the prognosis. The distal the injury at branches level somewhere, or sometimes the injury will continue from the roots to the branches. Say massive means how will you fill the gap? That 15 centimeters in a network of nerves. Where will you get? So next thing is, what is the timing of surgery? When will you time? As we have discussed, as early as possible. And post-ganglionic surgery in things, even at the end of 1 month or so, you can start. And the best things will be around 3 months, as we have already discussed. And up to 6 months, 3 to 6 months, it will give good results. And beyond 6 months, reasonably good result, okay result. And 9 months is average. And beyond 1 year, as I have discussed, 1 mm per day growth or 0.5 mm per day growth, it will take a lot of time. By the time it will reach there, the neuromuscular junctions won't be there. So the nerve doesn't find any target after traveling that far distance. So timing is very important. If a person comes beyond certain time, then we have to choose other techniques. Like instead of repairing the nerves, we'll go for tendon transfers, bar free functional muscle transfers. The result wise, they will give much less in comparison with the nerve transfers or nerve repairs. And apart from that, they will be much more difficult to do. Free functional muscle transfer will take 8 hours to do or 6 hours to do, and the result will be only hook kick. What's the point? So, how many types of nerve repairs are there? Nerve repair like direct end-to-end repair, nerve grafting, nerve transfers, of course, as well as tendon transfers and free functional muscle transfers. I'll tell you one important thing here. The nerve repair was invented in 1950s. Still, we are doing the same technique. Still today, we are doing the same technique. If any researcher can improve the nerve growth another mm, if it is 1 mm, if we can improve another mm, the time will become half. So the actual surgery, beyond 1 year also we can do surgery. And the recovery will be faster, the NMJs will be more, and the function will be more. So there is nothing is happening here. I myself tried something with nerve growth factors, not happy with the result. And there is another strategy how to preserve neuromuscular junctions. So some direct stimulation of the muscle can preserve the neuromuscular junctions. That we have tried. And that we need electron microscope and lot of patient cooperation and all those things. That is actually happening. We will see how it penetrates. Simply to discuss what can be done in these upper plexus injuries. What are different strategies. Anywhere nerve repair is possible is the best. End-to-end repair is best because one C5 root will have 5 to 6,000 axons. Whereas in the nerve transfers, whatever you do will have 1,000 axons. So you can see the scale, it is 5 times more. So that will give you definitely better input at the target, better number of axons at the target, and better function. So direct repair is the best. Next is nerve grafting, because nerve grafting will have 2 repair sites, and at the repair site there will be some loss of axons. At each repair site there will be some loss of axons. So in direct repair it will be 30%, but in nerve grafting it is 2 repairs, not 60% loss, but there will be definitely more loss. So the result will be much more comparatively less in nerve grafting. Other thing is nerve transfers. What are the nerve transfers? When you don't get the nerve roots, primary in the plexus, you don't, because there is avulsion from the spinal cord, and you don't get the primary root at all. So then what will you do? The patient comes to you late. Then you can apply nerve transfers. What are the nerve transfers? In the nerve transfers, you will repair the nerve, not with original nerve, but borrowing from other healthy nerve, which is comparatively not so important, or which have multiple innervations. You can take one nerve and repair at the target. Means, suppose if you want to repair the biceps, you will repair here. So that you will get the function in 6 months. So that's how you will repair at the target. Those are called as nerve transfers. So when the primary roots are not available, or when the patient comes beyond certain time, where you don't have the option of proximal repairs, you can take the nerve transfers. So here I have just mentioned few who are very famous. One is spinal accessory to supraspinatus nerve, which will improve the shoulder abduction. In 5-6 injuries, actually what he will lose? Shoulder abduction and elbow flexion he will lose. As we have discussed. Shoulder is controlled by 5 and 6-7 will control the elbow. 6 is flexion, 7 is the extension. So in 5-6, shoulder abduction and elbow flexion, the patient will lose. So we are replacing all these with these nerve transfers. In Somsax, we will try to transfer the triceps. Triceps will have innervation. We will transfer it to the axillary nerve so that the recovery of deltoid will happen. And in Oberlin transfers, we will transfer nerves to the biceps so that he will recover the elbow flexion. So to elaborate, an extended upper plexus means, so if you keep on going from next to next, T1 hand pan plexus, your availability of the roots will come down. So your availability of the input will come down. So we will limit the transfers, or we will borrow some other approaches. The routine things, nerve repair, nerve grafting, if the roots are available. If not, here if you notice, there is no Somsax transfer, because you don't have the triceps also in 5, 6, 7. Extension is also gone in 7. So you can't use anything for the deltoid. Likewise, you lose chance, and we will add some more things like intercostal nerves we can use for the axillary or triceps. In T1 hand, you will lose some more. Here you have only one root out of 5 roots. So bare minimum function he has, hand, finger flexion only he has, even he doesn't have the wrist function also. So in those, the options will come down even further. In pan plexus, all the roots were gone. So you don't have any other option. In these patients, we have adapted, we will borrow one healthy root. Suppose if entire right hand is gone, right hand is more important, he needs bare minimum function at least in the right hand, and as all 5 roots were injured, you don't have anything on that side. So what we do is we will borrow one C7 root from the opposite side to this hand for the hand function. So hand function will recover to some extent. I will show you the video how it will recover actually. We have discussed these tendon transfers, and these are few. Actually, he is a medical student. He was upper plexus injury, and of course, I am showing you the best results. Don't imagine that all the patients will get these results, but this is one of the best results. He got 5-6 injury. In these patients, we have used nerve transfer technique to show you. Is abduction, elbow flexion, and other functions. So here it is root grafting. You can see the root grafting how we did. So actually C5, C6 to the upper trunk. C5, C6 roots will unite to form the upper trunk. So we did the same anatomical repair there. And so in root grafting, you will get the result very late because the repair will be here and the target will be somewhere here. In nerve transfers, the target and repair will be nearby. So the result will be earlier. But what will happen in root grafting, the input is much more. So the functions he will get are much more. So what we have discussed, opposite C7 transfer in this patient. So it is, you can see the difference between the sizes of the hand, both the upper limbs. And the right side is very, very, in fact, leaner. So in this patient, we got left C7 function to the hand functions. That is his shoulder abduction. This is his extension elbow. His elbow flexion. And his finger flexion capacity. And the same thing in the pediatric age group. Here the result will be much more faster. We got the result in 6 months. Opposite C7. But in pediatric age group, we have to be careful that beyond 4 hours in pediatric age group, surgeries will derange so many things like electrolytes, hyperglycemia, hypothermia, all these things you have to take care very well during the surgery so that the untoward things doesn't happen. You can see the same finger flexion and elbow flexion are strength and so-called MRC grading. So this picture, what I am showing you here is actually signifies something. In this patient, we did simultaneously in our hospital 2 opposite C7 transfers. See, this I have shown you, even though we have transferred one root from the healthy limb, there won't be any deficit in that limb. So that's what they are trying to show you, the shake hand. So the dressing will be like that. The other hand, transferred hand will be in a cocoon dressing. That will be there for 6 weeks so that the nerve repair will cross the repair site. Afterwards, there won't be any chance of snapping of the nerve because here the donor is very costly. We got a normal root, right? So that's why we developed that. And in my experience, we did almost 60 to 70 C7 transfers or more. And till today, we have not seen a single weakness in the normal limb which given a donor. Western population, somehow, I don't know, they have the deficits and most of them stopped doing this. We and Chinese people are doing this. Maybe our, I don't know, dissection or distribution of the nerves, what God has given, we doesn't have the deficits. Thank you.
Thank you, sir, for offering us valuable insights into the latest advancements in reconstructive surgery and geriatric patient care. May I now respectfully invite Dr. Srinivas, sir, Professor Ortho Department and Life Member, Telemedicine Society of India, to felicitate Dr. R.B. Kuteshwara Rao. Thank you, sir. As we are already working within a limited time frame, here is a gentle reminder to all the esteemed speakers. Every presentation has been allotted a total duration of 15 minutes. A caution bell will ring at the 13-minute mark and the final bell will sound at 15 minutes. We kindly request all the speakers to adhere to the time limit to ensure smooth conduct of the conference. Digital innovation has the power to bridge healthcare gaps and bring quality services closer to every citizen. To speak on this important national initiative, may I now invite Dr. S. Uma Shankar to deliver his lecture on Ayushman Bharat Digital Mission, Transforming Healthcare Through Technology. Sir, may I request you to kindly address the camera.
Okay, good afternoon. First of all, I would like to thank the organizers for inviting me over here and giving me a chance to speak. And I also would like to take this opportunity to congratulate the organizing team, especially the Maheshwara team and the Telangana chapter, Telemedicine Society of India, for organizing this wonderful session. Can we all stand up and give them a good hand? Thank you. Thank you all. So I made you all stand for two reasons. One is we need to honor all of them. The other to know that you are all not sleeping and you won't sleep in the next 10 minutes. Okay. Let's keep the session more an interactive session. What you have been hearing from morning, this is about what people are doing and what is happening. And something I've learned new. What I'm going to talk now is about Ayushman Bharat Digital Mission, which has implication on each and every individual or every citizen of this country. Whether you are a citizen or people who are sitting here, you might be a doctor, you might be owning a healthcare facility, or you might have an organization who is running digital health or a company or something. So all of us have a role to play in this particular program. So this is a program of Government of India. I would not like to acknowledge that the content what I have received is from Government of India National Health Authority, and I'm also happy to announce or tell you that National Health Authority has recognized Telemedicine Society of India as their ambassador for ABDM. So as part of that, I'd like to talk about this ABDM. What is it? So ABDM. How many of you have heard ABDM? Let me be very clear. ABDM, how many of you have heard? 1, 2, 3, 4. At least not even 10. So, right. How many have heard ABBA ID? ABBA? All have heard? Yes. Okay. Now, how many of you have registered in ABDM? ABBA ID? Registered ABDM? Okay. Few. Okay, fine. Good. So, if you have registered, then that's good. What I'm going to talk about is what is ABDM and how do we register as a healthcare profession? How do we register? That's what we're talking about. Now, why did this come? This is the vision of the Government of India to create something as a national digital health ecosystem, you see, which can support universal health coverage through providing wide range of services to that. It could be as a citizen, it could be for healthcare, it could be transfer of data, it could be transfer of information, infrastructure, services, whatever you need to provide, bring all of that together in one platform. That is what. And that platform, whatever they do to provide, is secure and it provides privacy to the patient and also confidentiality to them. And all your personal health information is going to be in one particular place. That is what is a vision and of the government. So for that, there are two things. What they have worked, one is from the technology point of view, the other one is the policy. From technology, what they have told us, everything, information is going to come from one single source of truth. That means wherever you are, all information is going to come from that particular patient. And they are using a federated architecture. That means Wherever you have stored, if it is an example, I have my health information in hospital A. When I say that information is going to be across the country, so that information is going to stay in that hospital. Whenever you go to hospital B, information is going to get transferred from there to there. The total information is not going to work. Only they are going to get access to that information. So the patient is the owner of this particular information. And this can be done through open APIs. That is what they are doing. So for that, they have come up with policy. We have the privacy and security policy and user inclusivity. Everybody's, whoever it is, there is a rich, poor, prime minister, president, or anybody, all of them have everybody is included in this. And this is not something to be forced. Only if I want, I will register. It's a voluntary. Okay? And this is done so that all the citizens of this country have good health. So when we say good health care, because it means that when I go to a hospital, I get treated. If I go to another hospital for some other problem, whatever has happened before, it is for the benefit. So the other doctor also can get all this. So it is for benefits. So everything is done for betterment of the Indian population. So this is how it went. From 2017, there was a national health policy. Then in 2018, we had a national health stack. And today, in 2021, we came up with Ayushman Bharat. Because they are already one thing, I don't have time. So I'm just going to reduce some of these. So if you see one side, you have health information provider. It could be your public health programs, whatever programs you are there, or the doctors, hospitals, or the patient or diagnostic center. Wherever the data is originating, that goes to a building block through your health ID, whatever the ABA ID, whatever we call it. So there is a health information exchange which is happening. Right? And then that is through, it could be through your healthcare providers. All healthcare providers, they have their registry, and we're talking about that. Or it could be your health facilities, or the hospitals. Right? And who are the users of this information, who will fetch this from this building block? It could be same people who are the public health programs, the hospitals are the ones who will be used, and the citizens, we are going to use maximum. And it is like how you have a TV doctor, like that you have a health doctor. So this is what the architecture is generally looking at. Okay. So the implementation, as I told you, it caters to every individual, citizens, professionals, and residents. So anybody who is involved in healthcare will be part of this, and it has implication for everything. For citizens, it will be to ABA. For healthcare professionals, it will be to the EHR, HMAS, and health facilities, again to ABD. Right? Health registries are. So this is just an explanation of how it works, so let me not go into that. Yeah, this is an example. Now suppose there is one lady, and imagine this here, they have given an example of Rani Devi, who is 28 years old. Initially she had what she has used for, like she would have gone for pregnancy, for tuberculosis program, right? Then we have IDSP, so she had part of so many national health programs. And she went to, for pregnancy, for let's say, in third trimester or something. Then she has gone to multiple different hospitals, right? Every data is recorded in her. It's a longitudinal. So now it is like womb to womb. So from the time the pregnancy is there till that individual is going to die, so all that information data is going to be for. That's how it is going to be there. And each of them is not necessarily in one particular hospital. It may be multiple hospitals. The only thing they are going to share. And this control is with the patient. So this entire APDM is patient. It's all done as a patient has said. Right? So now how? What is it going to be beneficial for healthcare providers? Discoverability. That means once you get registered as a healthcare provider, you will be somewhere in a network. People can search for it. So you know that it is registered and it is verified. So now you are not applied. So that is one thing which I always said. Once you are registered, that means people know you are available. So you are using APDM. That means they know you are a verified, qualified doctor. Okay. And whatever we have the data, because it is longitudinal data, the patient's data for us, it's very easy to do diagnosis. to take care of their treatment. Right? And then this actually improves the patient satisfaction. And then you can go follow, and if required, referrals can be done, which actually saves time. Now, a practical problem when we talk about rural patients who come to hospital, they will bring a big bundle of reports. Right? All clinicians find it. I don't know how many of us actually go through the entire one. Few of them go through the whole. And that's a practically what we talk. But if we have everything, we actually save time. We only search what is necessary for us and we can go for it. That's the benefit. Okay? Now, how do we register as a healthcare provider? That's what I'm going to show you. Just step by step. So, ABDM has 4 registries. One is YABA. That's a 14-digit number. I think some of you are already registered. Then healthcare professional registry for all the doctors, irrespective of which system of medicine you are, whatever you are. Then health facility registry. It is for the clinics, it's for the hospitals, whether it's a corporate or a small hospital, nursing home, for all of them, and for drug registry. So these are the 4 registries which ABDM has created. Right? So how do we do? So it is for, as I said, it is for all the system of medicine. Whether you are Ayush, you are allopathic, you are pharmacy, for everybody. So you all can register. And how do we register this? So there are 2 categories. One is patient facing and the other one is self-facing. Okay. So what is the challenge and why do we need this? Why this was created? The first challenge is there is no universal existing database. That is, there is no facility which has catering to the entire system of medicine. So this ABDM has created that. It covers both for private doctors and for public, that's for government. And it covers across the system of medicine and also both for all the healthcare providers, to be doctors, nurses, pharmacy, everybody can be registered. Okay? And then we also have a lack of trust. Right? How, whether this doctor is good, this is not, whether they are updated, all those things. But this actually helps because the database is updated and then you know health facility is good. KYC is done, like how we do it in our banks. KYC is done, everything. So audit logs are there. Right? What patients are seen, everything is available for. Okay? And it has been verified. Now, if I register, that doesn't mean they are going to. If I register, it will go to the council and council will approve, then only it will get. So in that way, no fact can be registered. So you are registered, approved, verified from the governing council and governing council. So in that way, they got right. So benefits: online presence, trustable identity for the doctors. Then you can do teleconsultations, digital certificate. So you get a certificate from India, Government of India that you are registered for mobility. You can even now generate medical certificates for whomever required, as well as the exam. So how do we do it? You go to the ABDM website. So here is the link. So you can see this link. Go there. Either you do a registration or if you have already registered, log in and start using. Okay. So you go there. If you are logging in or registration, so you can go there to that. And then register. If you are doing it for the first time, go to register. Okay, new user, it's the form. And then once you register, they will link it with your Aadhaar. So you have to enter your Aadhaar or whichever license you have, government ID. Once you do that, then you submit and then you will get an OTP. Okay, it's a very secure platform. OTP enter in the submit. And now you are registered. So that is one. You have just entered. Okay, sign up is done. Now you have to enter all your details with your healthcare professional or your facility manager or your healthcare person, the facility manager, whatever you have to do. Whichever categories are categories, modern medicine or Ayush system, put all the details and submit. So now what has happened? You are registered. Right? Now is after you register, there is a verification. How does the verification done? They check with your registered certificate and then they come back, ask all your details. Okay? And then you have to enter those registration details. It will go to the respective council and they will approve and then it will get it will be done. So you can enter your work details and whatever you are doing. Right? So then you will get an approval. Once you get an approval, you get a certificate that your personal details are done. I'll show you the certificate how it is done. Please sign it. So this is your declaration that you have done. And it is all verified. See, the way it is verified, it goes to the state. From the state, it is verified, and it also verified, it goes to the center and it gets verified. So other features, as I told you, you can issue a medical certificate. Issue a medical certificate, whatever you choose the reason. And it is all documented, safe, and you are also safe. Okay, so for whomever patient you go, and you know that patient is already registered with AHA, and you give the details, and then certify medical certificate. And for who has given certificate, yeah, and you can download. So this is verified, so you are a digital doctor. So your details will be done, council has registered, it is signed, and it's not downloaded. So you can download that and keep this additional certificate given by the National Health Authority. So similarly, if you want to edit your profile, you can do. Right? So there are other features which I am not able to go to. This is for the individual doctors. Similarly, we have something which they have combined is for healthcare facility registration. So for a hospital, you can register. Right? So same process for the hospital. Your registration number, whatever details you are giving, you can register. Right? So whichever system of medicine whether your hospital 10 bedded, 100 bedded, what are the facilities you have. So it will tell you whichever departments you have, you can show the departments, total number, and the working hours, which department, what day-wise you can. And this helps for patients to search. Okay? So like that you can do. So this is for the health facilities and your submission will come. Yeah? Okay. So with that, I will stop here. If there are any questions, I can take up. And this is actually a 1 hour session which are trying to do it within 10 minutes. So it's so these are all processes. As you start entering, you will get everything.
Good evening, sir. This is Varda, and I'm an intern with Maheshwara. Sir, as a citizen, how can I be confident that my personal data is registered in the government website, as you have mentioned, that is an open interface, that is privacy is being maintained and that it is secure?
It is completely secure. It's your data, whatever. It's like how you go from giving that information to somebody else, unless you give the access to them. Let's say you have got hospital A, right? So you have given all your personal information, whatever information you have given. Right? Now you go to hospital B, right? And you want to give that access, right? And when you carry, you may lose it. I have seen a lot of patients who lose it in the past. This particular case, nothing doesn't. You go there, they will ask you your Aadhaar, and then they will, once you do, you will get, because it's linked to your Aadhaar, right? You will get an OTP. Only when they put an OTP, they will get. It's a complete secure system. Nobody is going to be able to see, and it is all encrypted. Even if they want to see, they will not be able to see. That's how it is.
Thank you, sir.
Just can you just put the slide? I just want to put. Yeah. So, because I also represent PSI, anybody who wants to become a member, you can use this scan. The application will be available. You can do it. This is one. Okay, for membership. And if you are registering today, you get a discount. I think it's already been announced. The second one, we also have a conference in the month of October end, October 30th to 1st of November. So you can scan the QR code and get to register. Thank you. Any other questions? Oh, thank you so much. I just took 1 minute extra.
Yeah, it's fine. Time, finish it.
Yes. Thank you, sir, for highlighting the transformative impact of the Ayushman Bharat digital mission on India's healthcare landscape. Distinguished delegates,
We now move to the last academic segment of today's conference. Behind every successful digital health solution lies a robust platform that enables innovation, collaboration, and efficient patient care. It is my pleasure to invite Mr. Ramana Satyavarapu to deliver his presentation on building the AI operating platform for healthcare. Sir, may I request you to kindly commence your presentation.
This one? Hello. Hello, can you hear me? This one? Or this one? Yeah, this one.
And also this one.
Hello. Yeah. Perfect.
All right, feel hungry, right? So you must be wondering, try and then go and eat for a healthcare. There's only one answer to it. You've got to be an engineer. And that's what an engineer, not a doctor. Not a doctor, super intrigued by what engineering and AI can do to transform our lives, make it better. What's the most important thing now? Okay. Somewhat, but not with. And I'm here to talk about how we can make it transform. That's that. All right. So let me give you a little context. So, what architects the global sector probably must have built Gina, using search box in Gina, that's my service. So, we was a big tech, and at a point in life and career where how can I apply my learnings to health? That's where. So, let me ask a simple question, right? All of you can answer this better than me. What is cancer? Cancer is a specific disease, right? You have the symptoms, some treatments, causes, etc. What does an engineer think the cancer is? An engineer thinks a cancer is a graph problem. It's data and matching algorithms to get to the right disease. And how do you get to that? It's called a clinical knowledge graph to get to that answer. That's how an engineer thinks. It's literally a graph problem. Don't believe it? Who was my previous boss at Google? He started a company called Liquid doing exactly the same problem, which is trying to detect cancer using T-cell B-cell combinations. And how many combinations are there in a human body? Roughly a few 100,000 billions. T-cell B-cells. How many diseases are there? About 26,000, and 4 new diseases are being found every week. Right? Now it's a math problem. For me, in my mind, I'm just thinking, how do I map those billion different combinations of T-cell B-cells to these 26,000 diseases? If I'm able to predictively map that, just imagine this is like elementary knowledge, and I'm here that between stage 1 and stage 4, the chances of survival are significantly different. But imagine your body is fighting even before it got to stage 1. So there has to be something in the body which is telling there's like a T-cell B-cell spike. So that is where AI comes in. It's not a mystery, right? It's basically numbers and math problems. All right. So, we are seeing AI in every aspect of medical field. This is a huge transformation opportunity. From the patient care to the physician's day-to-day experience and the entire hospitals are being run, completely run by agents. Again, I'm a proof fan. Engineers like proofs. The proof is Google just hired 500 doctors.
Wait, Google hiring 500 doctors for what? Just because of like how did they train their frontier models to get better relevance on Google's agenda? When you ask the disease or ask the symptoms, it gives you better diagnostics. 500 doctors. So you can just see the trend where the world is going, right? AI is going to be, more than AI, technology is going to be inevitable part of how human healthcare is going to be offered in the future. So, all right. By the way, last week we had the first humanoid, like a robot, perform a fully autonomous surgery of gallbladder removal. Fully autonomous, not like robotic arms controlled by a human. No, this is unsupervised. Unsupervised. Everyone knows. The human people know the difference between supervised and supervised. Supervised is but completely unsupervised, right? This is a big milestone in medical innovation. And this is not going to stop like there's going to be a lot more innovation going on in this space. Okay. So how big is it? Again, number set. I'll give you one fun example. Okay, before I was in healthcare and AI related to healthcare, I used to do at one of the quantitative hedge funds. We used to make money counting how many sheep are eating grass in New Zealand. Just looking at the satellite images, we made $32 million. Any guesses how that's possible? If you know how many sheep are eating grass over a 30 years history, you know how the demand or supply of wool going to be, and cross-correlated with how bad is the winter going to be in the US and Canada. You know, demand is going to be high, supply is going to be low by all the bootstraps. Maybe no one express 32 million. So that is just one example. If we can make 32 million out of sheep, how much money is there in healthcare? I mean, I'm not trying to sound very commercial, but it has to be like, we don't run non-profits, right? Some do, but we need to make it win-win for the customer and for us and the hospital. The overall efficiency has to be better. And now is the time, because everyone knows that like, inflation is crazy, right? Right? And you know the number one field which is going through the worst inflation ever in history is at 26.3% increase since COVID. So this is a $1 trillion opportunity just with generative AI. So just see that how big is opportunity. All right. So now let me be super frank. By the way, I mean, just for context, I live in New York. I just landed my flight yesterday night. Still trying to get back. So, giving you perspective from New York, the US has a massive power grip on the energy sector. That's exactly why US and someone else go to war. The prices of petrol go up. And everyone gets energy. China has awesome grip on rare earth materials. Proof of that, buy your iPhones or Androids now, the next iPhone is going to be $300 more. Right? China has grip on the silicon. What does India have? We are the knowledge hub. The future of AI is going to be data. And that is what we need to figure out a way in which we can be that data brain power hub that can be monetized and used as a leverage of advantage to the whole world. Again, proof. See how many of your colleagues, friends, etc. are like very successful doctors and settled in like UK, Europe, and US and other countries, right? Why? We have the brain power. How do we convert that brain power into a monetizable commodity? That's what we'll touch on briefly, but that gives you a picture of what we're sitting on. India is sitting on a gold mine because the AI is useless without the data. So, just a little bit about why it's become like such a big wave or commotion about AI right now. Because it's an invention of Transformer. Not the movie Transformer, by the way. Not the movie Transformer. We are talking about GPT, generator, pre-trained, Transformer. Right. GPT, that single article was released by Google in 2017, and that changed how large language models are commoditized with Google. Okay. And now, previously, to set up a single model, it used to take tens of millions of dollars. Now, few tokens, and you can access any model in the world. And data and computers, especially healthcare, needs more predictive high fidelity data to give predictive results. Okay. So, again, our esteemed colleagues and others have touched the importance of responsible AI. I would like to cover down on this. Responsibility comes back. It's a must. How many of you know of this term called, I might be wrong in pronouncing it, Vishwam? Anyone heard the name? GPT. You will see Vishwam, here is the treatment, etc., etc. By the way, that's a fictitious disease. There's no disease called Vishwam. It's a disease that was created by a doctor in Sweden just to prove that you can gain these LLMs. It's very much like that movie, 3 Idiots, where American invents these two words, right? Like Fahrenheit and fragility and something like that. It's very similar to phenomena. Okay, invented. And all the models go follow it like a herd of sheep, saying that yes, that is a real problem, that is a real disease, and starting giving treatments to it. So we need very responsible, high fidelity, curated data. That is going to be the lifeline of future healthcare, all the frontier models, to serve better results. Because these are life-changing decisions, right? If someone is going through a GPT and searching for something which can give a wrong answer, and the person might take a wrong step. The responsibility is very, very high. It's life and death. You can't take a chance here. Right? So with that, these things in mind, we have me and my co-founder, Raghu. We have, by the way, Raghu is served as the CEO of GeoHealth before. We go long back from Microsoft days. So we started Elivia. Elivia, how does it give 10x efficiency? Every physician, how does it make them 10x more efficient? And how do we create an Uber of data, of medical health, healthcare, etc., that can be served to the frontier models that can give us very high fidelity results. So that's the work, that's the thinking. We just started a journey on this. So here I'm not going to say anything about Olivia, but pretty soon, all of you, I'm hoping, will be part of the Olivia networks to replicate your knowledge into the model brains. So that's the dream, that's the ambition. I know we have a long day, but thank you for having me here. Huge respect for doctors, because I understand machines, and all of you understand people are 10x more difficult than machines. Again, true. Machines, GPTs hallucinate once in a while, but people hallucinate all the time. Right? So, you all are better equipped at treating people, and my job here is to capture some of that data to train the models. As simple as that. So, thank you. Thanks for having me.
I thank you a lot because yesterday night he landed 1:30. I requested him a day before to attend this event and give a speech because he has a lot of experience in AI. We wanted the knowledge to be shared with him. He really accepted today when session he called me. I couldn't respond. Still, he made it here. I'm very thankful to him and for his ideas. Big applause. Big.
Thank you so much.
Thanks a lot, Mr. Thomas.
Thank you very much.
We'll go into honor him.
Thank you, sir, for your valuable insights into the role of AI platforms in transforming the future of healthcare delivery. May I now respectfully invite Dr. Srinivas, Professor Ortho Department and Life Member Telemedicine Society of India, to felicitate Mr. Ramasidhya.
Thank you.
Thank you, sir. As we approach to the conclusion of this memorable gathering, I now invite Dr. Rajan Kumar Brindari to deliver the closing remarks. Sir, may I request you to kindly address the gathering. It is
it is now time to honor individuals whose contributions have made a meaningful impact in advancing healthcare and telemedicine. We now commence the TSIT Awards 2026. The first award, Excellence in Community Health, is being presented to Dr. Karunakar Reddy in recognition of his distinguished contributions to community healthcare. May I respectfully invite Dr. Ramachandra Vishnu Bhatta to present the award. Congratulations, sir. The next. So we request you to please address the gathering with a few words.
We're working in the area of quality so I'm managing the Vishwam Trust. Practice international planning for 25 years in medicine. Involved with the country. So I've been there. We started the trust called Social Trust, and here 10 years of trust. We have been objectives, make explain villages, and rural type of areas, and for other communities in rural areas, and urban urban location. So now the concept is not the thought that not working out, we will stages of consolidation, and then we will start stages scale. The communities what we have come to provide in rural areas of digital health, all the schools, problems of these types, and then we provide the city centers, so they get this complete quality free education, where the children are taking the value high quality, like the corporate education, and then we have got 53 schools now, 18,000 children. Anybody can be there in the each step. That's the corporate, and here in this particular branch. So we're talking about telemedicine, the providing quality, telling yoga, in rural areas. The vehicle communities is all equipment, so we have high quality equipment. And that's what we do. High quality workforce. We have something like state centers where they go to the state and then they get the job. So that the village becomes successful. So in other words, they are tangible self-sufficient villages. So where the people are in poor areas are
I would request everyone to please give him a standing ovation. His work deserves a big round of applause.
Everybody is welcome to it. So if anybody wants to pay services from US here, they don't have to come and visit the areas, you know, at home. And trust me, none of the first I'm very good at this. And I trust me again, the person has satisfaction in whatever they approach. Thank you very much.
Thank you, sir, and congratulations once again. The next award, Excellence in Remote Care, is being presented to Mr. Uma Mahesh, sir, for his noteworthy contributions towards advancing remote healthcare services. May I respectfully invite Dr. Ramila Murthy to please present the award. Congratulations, sir. The next award, the Trailblazer Award in E-Sanjeevani, is being presented to Dr. Rajiv Kumar in recognition of his pioneering contributions to the advancement of E-Sanjeevani services. May I respectfully invite Dr. Prasanna Raj sir to present the award.
So, Dr. Umashankar, yes. Join us. Join us.
Thank you, sir. A brief reminder, after the vote of thanks, we will be having a group photograph session. So I request you all to please stay back for the group photograph. Gratitude is the most fitting way to conclude an occasion built upon collaboration and shared purpose. To propose the vote of thanks, may I now invite Mr. Uma Mahesh, Treasurer, Telemedicine Society of India, Telangana Chapter. Sir, may I request you to kindly address the gathering.
Good evening all. Respected dignitaries, ladies and gentlemen, this is Uma Mahesh, Treasurer, Telangana TSI.
Before the vote of thanks, we have a technical presentation by Mr. Ali, Syncade Technologies.
Good evening, everyone. I know I've come to the, it's like the 20th over and you've come on the pitch when 3 balls have been already bowled. So in my last 3 balls, I'll not take a lot of your time. Just a small introduction of what I represent, and it will be worth your time. Okay, am I audible? Yeah, great. We at Syncade Technologies looked at a challenge that post a patient leaves the doctor, there is no clinical observation. Whether the person leaves the hospital or leaves the OPD, there is no clinical observation of that patient. Now this patient, obviously the clinical cycle doesn't get over immediately after leaving the hospital. Somebody may have been operated, So they have to come back to the hospital, or the journey, the clinical journey in terms of recovery is on. And sometimes it is on for months, sometimes for years. Today, I've seen doctors explaining that cancer has become just another disease, but you have to live with it for all the life that you have, which means that you have to be cautious all your life after you have been treated. So we created a product called as Carely. Now Carely looks after you. Carely works as a mobile application for the patient, and it also has got a dashboard with the hospital. A little, focus here. Something very new that India and overall, I would say the whole world has not seen, because it's a new product that has come up, and we have been comparing it with the kind of services which are available and wanting to launch in US. I heard you. In fact, I'm very, very in this hurry. I could not say thanks to anyone, but yes, I would certainly relate with what Dr. Ajay Kumar was talking about, and it completely relates with it. Thank you so much. So here is a product which serves from a mobile application for the patient, and there is a dashboard with the hospital or the doctor. Now the mobile application looks after this patient with respect to symptoms. Whichever ailment somebody has, a different template gets activated because of the AI, and this template looks after the patient every day with the help of 15 to 18 questions or 20 questions, completely customizable. And this becomes you can import data on the application. Third thing is about the medicine adherence. For medicines, everybody says that, medicines are important, but after somebody reaches home, how many times actually people, take those medicines as religiously as expected? So the product that we have created has not only got the reminders for medicine, it also has got the kind of accountability to be built for taking the medicines and recording it. So which means the adherence is recorded. It means the audit for having taken the medicines is done. So if somebody was given 6 medicines a day, it not only reminds them that you have to take these medicines, but it also records have you taken them or not, so that the next time when you visit the doctor, have you consumed 60 or 50 or 55 or 45 or whatsoever the number be. Right? So by this digital nurse check, which is done daily, which can be done multiple times daily, by the recording of vitals manually or over the system, and by the medicine adherence, we are creating this gap which used to be that there is no clinical observation for the patient until the patient goes back to the doctor. Now, the entire story that you have heard about, what happens with the patient, there is a reflection of it at the hospital. Now, all of this is seen visible at the hospital. However, there are interesting alerts that if a person deviates from the regular course of recovery, I repeat, if a patient deviates from the regular course of recovery, there are alerts to the hospital or the doctor, which means that the hospital, right, and which means that, right, it also means that, when I start feeling unwell, I may not have a commitment to go back to the same doctor, same hospital all the time. So it is also serving like a CRM for the hospitals to maintain this relationship, that your staff, which is working on the dashboard, which we call as a nurse dashboard, the nurse command center, connects with the patient and says, "You're not well, come back to the patient." In the days when the patient was not giving you any business, is also business. So which means that what we're talking about is a fantastic continuum of care, something which honors NABH 6, right? And a fantastic business for hospitals, because you are able to look after the patient in a way superior manner. Thank you so much. I could bat only this much in the 3 balls. Thank you. Any questions? I can expect that. Thank you so much.
Thank you, sir. Gratitude is the most fitting way to conclude an occasion built upon collaboration and shared purpose. To propose the vote of thanks, may I now invite Mr. Uma Mahesh, Treasurer, Telemedicine Society of India, Telangana Chapter. Sir, may I request you to kindly address the gathering.
Doctor who? Is someone going to come up? Now, there is a video presentation about Sukino Digital Health being played on the screen. I request all of you to please pay your attention on the screen.
Telehealth today is fragmented. Devices don't speak with each other. Systems don't exchange data. Clinicians struggle with incomplete information, and patients pay the price. Saffron by Sukino changes this landscape with a fully integrated AI-powered teleclinic built for precision, interoperability, and scale. At its core, Saffron is a holistic and personalized telehealth solution designed to bring diagnostic-level measurement to the local point of care, while the cloud handles the intelligence, computation, and long-term analytics that make community-based care affordable. The platform offers an open interface architecture designed to unify the disjointed medical technology ecosystem. Saffron's device integration layer, or DIN, acts as a gateway for all third-party medical devices. Whether it's a basic writer's monitor, a waveform generator like the ECG, a digital imaging device, or a streaming instrument, DIN interprets each device's output into a canonical format. This device-agnostic strategy gives choices to clinics and may also allow them to plug in the equipment they already have, thereby reducing the cost of deployment. Above DIN is Saffron's information acquisition, abstraction, and transport layer. Here, clinical data is captured, normalized, encrypted, and securely transmitted. The system handles real-time communication, offline uploads, multimedia distribution, and session-level context, all through a HIPAA-compliant architecture designed for high availability. Once the data reaches the cloud, Saffron's storage and distribution layers manage it through optimized repositories using MongoDB. Intelligent partitioning ensures that structured and unstructured data moves efficiently across the platform. Recorded sessions, annotations, device streams, and clinical reports are all archived and transferred to integrate seamlessly with existing environments. Saffron allows integration of EMR or
I invite Dr. Ramila Murthy, sir, to please say a few words.
I will not say words, but one word. This saffron product from Sukino is launched in India from June 1st, 2026, and I am heading the operations for India. And anybody interested can get connected with me. And this is a platform with 10 devices as of now, providing real-time data to all the 640 video conference, all the participants. Thank you.
I now invite Mr. Uma Mahesh, Treasurer, Telemedicine Society of India, Telangana Chapter, to propose the vote of thanks.
Respected dignitaries, ladies and gentlemen, it's my proud privilege to propose the vote of thanks on behalf of the organizing committee. At the outset, I express my deepest gratitude to His Excellency Honorable Governor of Telangana for his gracious governance message and encouragement towards the telemedicine and sustainable healthcare. I extend my sincere thanks to Dr. Ramchandra Vishnubhatta, President of Telemedicine Society of India, Telangana Chapter, for his leadership and guidance. I sincerely thank Dr. Uma Mahesh, Honorary Secretary, Telemedicine Society of India, and Dr. Ramila Murthy, President-elect, Telemedicine Society of India, for their dedicated support. I extend my heartfelt appreciation to all the distinguished national and international speakers, esteemed faculty, members, delegates and sponsors, and participants. We thank Maheshwara Medical College and Hospital for hosting this prestigious conference. Special thanks to the faculty and the organizing teams of Maheshwara Medical College and Rajarajeshwari Medical College for their tireless efforts. We gratefully acknowledge the IT department, medical department, housekeeping, security, transport, and attendance services for ensuring the smooth conduct of the conference. Our deepest gratitude goes to our respected chairman, Sri T.G.S. Mahesh, whose visionary leadership and generous support made this conference possible. Before I conclude, I am delighted to announce two initiatives of the Telemedicine Society of India, Telangana chapter, during this conference, which offers a 10% discount for the life member and also the student membership. For the newly members, we are also proudly announced the launch of Student Chapter, which will provide medical students with opportunity for learning, research and mentoring network, innovation in telemedicine and digital health. Finally, I thank every delegate, volunteer, student, and a member of the organizing committee whose dedication made this conference a grand success. Thank you all once again. We wish you the safe journey home and look forward to meeting you again at a future TSA. This is Uma Mahesh signing off. Yeah, we have there's one more announcement here. So every year there is in Jaipur, it's a prestigious event that's called International Telemedicine on AI, and it's on October 30 and 31st. There are 2 days. There's 2 days.
We literally pulled them out of the examination hall day before yesterday for the rehearsals and going through the script. Last month we had the graduation day ceremony, and we had a book release of the newsletter. Okay, and I request Chandushri and Sneha, who been final year students right through their exams, have contributed tremendously. But during the graduation day celebration, they were having their final year exams. There are 3 students, Sarvagna, Chandushri, Chandushri. Continuously doing that, managing the IT for the last 3 days. Every last minute change, he's been immediately making it on his lap as well as on the tab. Thank you so very much. So, could you please rise and we all owe him a standing round of applause as well. Thank you. Thank you, sir. Next.
And a special special thanks to our Dean Syed sir.
Thank you, sir. May I now request everyone to kindly rise for the national anthem. As we conclude today's conference, we extend our sincere appreciation to every distinguished speaker, honored delegate, and esteemed guest who has been a part of this memorable gathering. Your presence, your insights, and your active participation have been the true strength of this conference. We hope the discussions and collaborations initiated today continue to inspire meaningful progress in healthcare and contribute towards building stronger, healthier, and more sustainable communities. On behalf of the Telemedicine Society of India, Telangana chapter, and Maheshwara Medical College and Hospital, it has been a privilege to host you
and we thank you for enriching this occasion with your valued presence.
May I now request all our dignitaries, guest speakers, and members of the organizing committee to kindly assemble for the official group photograph. We request all the dignitaries to grace the dais for the group photograph, and all the students will be standing